What's that? Okay. Good morning, everybody. And thank you very much for making your way to the hotel so early this morning and giving up your weekend time. My name is Neil Nijawan. I'm a consultant in palliative care. I work for Bujil Medical City in Abu Dhabi. And I really want to say thank you for coming and supporting us at the very, very first palliative care conference to be held here in the UAE. I suspect more people are going to turn up as the day goes on, but we're already running a little bit late and we have around 500 people online already. So we're going to make a start, and then a bit later in the morning we'll crack on with the official opening ceremony. So we're going to start with the first session, session number 1. And our first speaker today, my bio is there. So first speaker today is a very, very good colleague and friend, Dr. Raja Gopal. Dr. Rajagopal is a palliative care physician from India. He's the founder of Pallium India and a pioneer and globally renowned in palliative care. He established the Pain and Palliative Care Society in Kerala, which became a WHO demonstration project and expanded the network into community-based palliative care centers. Dr. Rajagopal also played a key role in simplifying narcotics regulations in India to improve access to pain relief. He's the chairman of Pallium India and director of Trivandrum Institute of Palliative Sciences. Dr. Rajagopal was elected as lifetime IHPC board advisor in 2012. So it's my great honor and privilege to welcome Dr. Rajagopal to open the conference and first session. Thank you.
What a privilege, Dr. Humaid, Neil, and dear friends from various parts of the country. I am indeed glad to have this opportunity to share a few thoughts about some things that are common to my country and the Middle East, though most things are very, very different. We belong to a low middle income country. You are in a high income country. But what is common is that we all belong to the global south, except for the few guests from the global north. There are many things in common about the things that I am going to talk about. I believe I have some important things to convey, and that we may be able to think more about it, if not at this conference, maybe in succeeding conferences, about those important things. Terry Kettering wrote this poem, which some of you may have seen. There is an elephant in the room. It's large and squatting, so it's hard to get around it. Hey, this elephant got into the healthcare room a long time back, and it started growing. Now it has grown so much that it is choking and suffocating us. We pretend not to see this. We certainly pretend not to see it. Yet we squeeze by with, "How are you?" and "I am fine," and pretend that the elephant is not there. Maybe we are now scared to look at it. I'm going to talk about that elephant within the healthcare room. We said, excuse me, can you help me with this monitor which has gone blank? We said the healthcare room. Let us just reflect. We still believe in the WHO definition of health. That health is not only physical, not only absence of disease or infirmity, but is complete physical, social, and mental well-being. Physical, social, and mental well-being. Tomorrow, if I come to your hospital as a patient, Is that what I am likely to get? Are you going to assess my physical, social, and mental well-being? Or are you only likely to look at my disease? I must confess, as a medical student and as a doctor, I was taught about the human body, the microbes, the organs. And I was not taught about the person, the human being. There was nothing, almost, except a bit in the community medicine department about people or their suffering. So if we are to get rid of that elephant, I love elephants, in their right place and time, not within my room. And if we are to get rid of this, to get it out of the room, we have to know what it is. We still believe all this, don't we? Globally accepted that healthcare should be promotive, preventive, curative, rehabilitative, and palliative, sort of balanced. Really? Or are we in sheer imbalance, where everything else takes a back seat? All that gets attention almost exclusively is diagnosis and cure. That's unhealthy. That's bad for my health when I am your patient, when I should be getting attention to my well-being. We need to get that balance back. I know that all that are important, but as a palliative care physician, pardon me, I am going to give more attention to the palliative aspect of it. Because without that, I am convinced that well-being is not possible. But we first need to decide what is palliative care. The concept is evolving. When WHO defined it first in 1986, which was published in 1990, this was palliative care as an approach aimed at treatment for quality of life when the disease was no longer responsive to curative treatment, which of course caused a huge problem, which meant that suffering was ignored all through the treatment process, which may last for a year and a half, and then in the last few days you come with all your compassion. Where is the sense of that? So WHO redefined it 22 years back, rather outdated, where they mentioned that it was for improving quality of life in all life-threatening illness. That's fine, so long as we all have clarity about what is life. If it is a beating heart, is that life? Or is life something that's a little more than that? Something that includes some enjoyment of life? Some contribution to the world around me, my family, my friends? Unfortunately, very often, especially we of the medical system, are concentrated on that beating heart. Which is why, even when for someone inevitably moving towards the end of life and who is suffering every moment, we'll still tend to stretch that suffering out by our artificial life support systems. My good God, is that health? Is that health to make that dying process stretch out over 2 weeks? I'm scared, friends. I am mortally scared. I am not afraid of death. But, sorry, I am afraid of dying in hospitals precisely because of this. So, the problem with the definition was, unless we are sure that the person was dying, they are often denied palliative care. Thankfully, in 2017, the Lancet Commission on Access to Palliative Care came out with this phrase, serious life serious health-related suffering, SHS. Okay. If there is suffering due to a health issue, then that deserves palliative care at any stage of the illness. The concept itself is simple, so what is so special about it? But it brought the focus so precisely on suffering that Dr. Richard Horton, the chief editor of the Lancet group of publications, wrote an editorial on it, and in that editorial said, medicine can never be the same again because it focuses on the suffering. Of course, we don't change so fast, do we? We go through a laid down path and are afraid of deviating from it. So I'm sure it will take some time, but the move is inevitably happening. We are going to have, we all are going to have to address suffering. Before, well, if we don't change, the change will be forced on us. Now, one problem there is who decides what is serious health-related suffering. So will Dr. Neil Nijavan sit here and say, oh, no, your problem is not serious enough? Of course not. That's not possible. How do we decide that? By looking at data. And where do the data come from? Friends, this we need to think about. We all generally are proud of evidence-based medicine, which means we need the data. Where do the data come from? It would be important to think about it. 15% of the population live in Euro-American countries. And 93.5% of data come from there. 6.5% of the population from the global south come out with only 6.5% of the data. What does that mean? That means that when I am in that bed, what is my suffering will be decided by you based on the Euro-American data. Not fair. The data do not show my problems, do not show the extent of catastrophic health expenditure destroying people, including my family, do not show many social and emotional components of the suffering, and therefore, and does not see the fact that my family is poor, my hut is no longer thatched this year, and you are giving me all the medicines, and I actually saw a man with advanced cancer holding an umbrella and sitting up, unable to lie down during the monsoon because the whole roof was leaking. Hey, is that the job of the healthcare system to do anything about it? Health is physical, social, and mental well-being, right? In the 2017 Lancet Commission report that we talked about, they took into consideration 20 disease conditions. Why only 20? Well, disease groups, because that's what data were available for. And in this, you can see the commonest global condition causing serious health-related suffering was HIV and AIDS. The next was cancer. Then came neurodegenerative diseases and dementia. These were the commonest. Oh, there were many others. The problem is, some kind of data from which extrapolation was possible, was available for these 20 diseases. But how about the tens of thousands of people in our country with spinal cord injury and quadriplegia and paraplegia? I know it may not cause so much of suffering in the global north. They get the spine fixed, and 3 months later, you see them, the person in the supermarket doing his own shopping or her own shopping. But not in my country. A spinal cord injury is a sentence to slow, painful death, confined to 4 walls, repeated urinary infections, pressure sores, loneliness, and that's what it is. Post-stroke paralysis. How about people with chronic pain? In the global north, there would be a pain medicine field giving what they can. But how about in the global south? That is not a fashionable speciality. And how about people with drug dependence? Well, would palliative care units take care of these problems? We do, within our limitation, what we can, because we refuse to be constrained by those definitions. How about frailty of old age? That is dreadful in countries like ours. Now that the world order is changing and the young people are flying away, what happens to all those millions? And how about acute pains? I have unending admiration for this nurse in Uganda who went upon the podium at a conference and said, if you ask me to see only chronic diseases, I cannot. She was confronted with a woman in obstructed labor and said that by definition she doesn't come into palliative care. I dispute that. In the official definition there is no word chronic. But the girl says, she is one of my people. I cannot walk away when she is suffering. And she defines the humanity that should be in all of us, who would refuse to be bound down by definitions and look at suffering. One of the major problems in our global south is the lack of access to pain relief. This hugely distorted world map is from the Lancet Commission report, where you can see USA, Canada and Australia having morbid obesity, and most of our countries are hardly visible. India is a thin line there. This is dependent on access to pain relief, access to opioids, which translates to access to opioids. In the Middle East, as well as in poor countries like ours, pain is largely left untreated. Leave alone pain, any form of palliative care reaches so few, so that people with diseases causing serious health-related suffering are left to live for any length of time and die in pain. Those are the countries called Global North and Global South. It is not geographically North and South. You can see that Australia also is included as Global, Australia and New Zealand are included as Global North. But whatever I am saying is common to the whole of Global South. Unfortunately, not only are we not treating that suffering, but we are worsening it. Catastrophic health expenditure destroys families, particularly in middle-income countries. Low-income countries escape because they do not have adequate access to health care. Because if you have health care, you have your health destroyed. Look at those numbers. In my country today, things are becoming so bad that more than 4% of the population, 55 million, okay, even that is 2015 statistics, it must have worsened a lot now. 55 million people are driven below poverty line with catastrophic health expenditure. What kind of health care is that? Friends, we have to drive that elephant out of the healthcare room. It has grown so huge that the door, it cannot pass through the door. We may have to break open a door or two and somehow push it out? And do we have the strength? When there are competing interests, including the commercial interest, favoring many of the ills of healthcare system, how do we do it? How do we break down the shackles of the guidelines and definitions that bind us in the global south? If we are to break free of those shackles, we will need community participation. This is the scheme that I am going to talk about for the next 5 minutes. You see the middle panel. That tomorrow will account for the most reduction of health-related suffering. That is, by what was resolved by the World Health Assembly in 2014. This year, the theme of the World Palliative Care Day a week back was 10 years of the resolution, where are we? I can give an answer to World Palliative Care Day and tell us that there has been a difference in the global north, but nothing at all in the global south after 10 years. If tomorrow, friends, I am coming to you as your patient, maybe mortally wounded, maybe in my last few weeks or months, if I am to get any kind of relief, every single healthcare provider should know the basic principles of palliative care. Like I believe will happen in somebody in London in UK. I'm glad you are here from St. Christopher's Hospice. Any doctor would prescribe morphine if somebody is in pain. They can, if they consider it necessary. Any nurse, I hope, would understand the principles of palliative care and psychosocial support, any social worker, any healthcare provider, physiotherapist, pharmacist, everybody. Only then suffering will be treated. I know there will still be elements of suffering that any nurse or any doctor cannot treat adequately, and then specialist palliative care centers will be needed. That's the top panel. Only for those. For the majority, it is what every healthcare provider provides. But can you do it? I told you about the man holding up the umbrella during monsoon. How can doctors and nurses do anything about it? We don't have to. How many years, my God? 46 years back, the Alma Ata Declaration, which we all studied about in community medicine or public health, Alma Ata Declaration resolved that healthcare can be healthcare only if it is done in partnership with the community. 40 years later, the same world nations got together again, and now the then capital of Kazakhstan, Astana, came out with the Astana Declaration, which again proclaimed healthcare has to be not only in partnership with the community, some ownership, some control over healthcare has to be given to the community. And what difference will it make? I'll tell you what it makes in my state of Kerala. Kerala is that tiny state deep south in the huge country India, with only 1% of India's landmass and 3% of the population. 3% of the population, terribly overcrowded. That's why most of us are here in the Middle East and not in Kerala. But in Kerala, we engage with the community. They are made partners in care. Like most people elders following a fracture femur in our country, they would have the femur fixed, but they'll never get up again and walk because they'll get no rehab. That man behind, Mr. Francis, the man in white, the volunteer leader in that small area, he has made sure that she gets up and walks, some support is given. He and our team have trained that granddaughter to help her to make her walk again. What a remarkable difference. How laughable is our surgery where we fix the femur and leave her to walk never again. Sorry, can I have a glass of water? And they can get healthcare across to levels which, I'm sorry. Thank you. Yes. Okay, thanks. And what our volunteers did for that man holding up the umbrella, that Saturday, they took a huge sheet of tarpaulin and pulled it over the hut. I couldn't have done it as a doctor. Nurse couldn't have done it. But we engaged with the community and they work miracles. And during the World Palliative Care Day, a few years back, our volunteers organized an outing for our home-bound patients, many of them wheelchair-bound. 160 engineering students came from 2 engineering colleges, 4 to 1 home, picked up the people, carried them to the road, brought them in a vehicle so that they all could get together and enjoy an evening by sea. Is that healthcare? Physical, social and mental well-being? I would consider that the pinnacle of healthcare, which professionals alone could not have done. And you see this girl with in green and red on the front, hanging on to her friend's arm to share the happiness. She's a paraplegic, does not have normal sensation in her legs, and she said, "The waves touching my feet was the best experience that I have had in my whole life." The needs would be different, I know, between Abu Dhabi and my city of Trivandrum or Taiwan or Vietnam. The needs would be very different. But we are all human beings. Life would be defined the same way for all of us. Health should be defined by the same way for all of us. The magnitude of the expense may be next to nothing, but it can be done. How do we ensure this community participation? The World Health Organization suggests that the change has to occur at the macro level, meso level, and the micro level. At the macro level, because those who govern the country, the lawmakers, the legislators, the bureaucrats, all will have to accept that healthcare is not something that they throw out to the masses. It's something to be done in participation. The middle level, the meso level, would be suppose one hospital chain decides to integrate palliative care into their healthcare, which may mean that they allow some volunteers to come into the community, to be with into the hospitals, to be with the lonely patients in the lonely hospices or people in their lonely homes. And micro level, just one hospital, one clinic, accepting this principle and making it happen. And at all these, the principle would still be, if at all possible, start encouraging community participation. In our organization, Pallium India, our strategies, we call it D, E, and F. Demonstrate this actually happening, make it happen, educate professionals and the public, and facilitate development of new palliative care facilities, development of legislation and policies, and educating the professionals particularly, but also improving public awareness. This is what we do. I think I'm sure my time is up. I'll wind up by just summarizing my key points. You and I have a responsibility, we accept the responsibility to address all serious health-related suffering as we treat diseases. for which we integrate palliative care into healthcare, and that would be a balanced healthcare, both curative treatment and all the other 4 components of universal health coverage. To achieve that, we open the healthcare door to the community and welcome the community to come in. At macro level, the health minister maybe, to the meso level, the government system, healthcare system or the hospital chains, and the micro level, individual practitioners and hospitals. And we make this happen, but to propagate it, we demonstrate, educate, and facilitate a balanced program for the global south. That's my important request to this group. Somebody has to take the leadership on behalf of the global south. The World Health Organization does not have a program specifically dedicated to the global south. Everything is for the whole country, which practically manifests as everything is for 15% of the population. For our needs, somebody has to take the lead. And I request you all to consider being those leaders for a balanced healthcare system. Thank you very much.
Thank you so much, Dr. Rajagopal, for that eye-opening and very humbling presentation. We will move on to the second presentation of the morning, and we will leave questions till the end of the first session. So again, my very, very great honor to introduce Professor Justin Baker. Dr. Baker is a pediatric oncologist and palliative care physician, and is also a phase 1 clinical trial investigator. He is aware of the distress in children with advanced cancer and the ethical issues of their disease. He's the chief of the Division of Quality of Life and Pediatric Palliative Care at Stanford and the director of the Qualo program. He serves as the Associate Chief Quality Officer for Patient Experience and Holistic Care and previously directed the Pediatric Hem-Onc Fellowship Program at St. Jude's. Dr. Baker's research, funded extramural, focuses on phase 1 trials, adult and young adolescent palliative oncology, end-of-life care, decision-making, grief, and integrating palliative care into pediatric oncology. Dr. Baker is a prolific author with more than 250 academic works and is recognized to be a global expert in pediatric palliative care. So the floor is yours, Justin. Thanks very much.
Thank you all so much. I need to make 2 requests. First, we need to do this again, and I would love to be there in person with you. I'm so sorry to not be there. And second, I would love to be there again with Dr. Raj. There is no better person who could represent for the Global South as he was speaking. And Dr. Raj, I'm going to take that up. I would like to be a part of representing the Global South. So thank you for that call. I'm going to speak to you all today about the essentials of pediatric palliative care, that they are not just little people, but my one thing that I want you to remember is that there are actually more similarities in caring for children than there are differences. And almost everything that Dr. Raj spoke about is applicable for the children. And a very quick statistic, we now know that approximately 21 million children across the globe need pediatric palliative care. So today I'm going to speak very briefly with you about some of the differences between adult and pediatric palliative care. I'm going to talk to you about some key practices that are also similar. And then I'm hoping that I can inspire all of us, especially my adult palliative care colleagues, to reach out to care for the precious children. Because these kids, just as Dr. Raj was speaking about, these kids do not have people advocating for them in an effective way, and they are not receiving palliative care. I'd like to share with you first a video of me and my team. This is when I was at St. Jude, and this is in part what palliative care is about: integrated early, and working with this precious patient as she was leaving us.
When I think about Jessica, I am immediately reminded of her smile. You would walk in the room and right away you would know what her mood was. And boy, when she was in a good mood, that smile would light up the room. And boy, when she was not, she would let you know.
You couldn't meet Jessica and not remember her. She loved the staff, she loved entertaining. She knew she had a gift for making people feel good, and she loved to use that gift.
She was always full of life. She loved to joke. Oh, she was a Florida Gator fan. For the art teen show, she made a poster with the Florida Gators that was chomping up the cancer.
She believed in her heart of hearts, as did her parents, that she would absolutely be cured. And it was with that spirit, that spunk, that larger than life attitude she approached every day. Then when the tumor started coming back, it just came back raging. At that point, there really was very little that we could do to control it, certainly not cure it.
As it became more and more obvious that she wasn't going to be out of the hospital for the remainder of her life, it was all about how can we make these days brighter for her.
Jessica asked if she could have a puppy from the Make-A-Wish organization. Having a puppy in an inpatient setting is not a simple feat.
Anytime you enter an animal into this environment, there are so many things that have to be done.
We can't just break every rule and say, okay, well, let's bring the dog in.
You have to think about people with allergies, people who don't like dogs.
The fact that we have other patients here too.
Where's the dog going to be? Where's he going to stay?
Who's going to be responsible for the dog?
But with all that consideration, how can we make it happen?
Just to make that one event happen, so many people have to be involved in that.
No matter whether it's infection control, nursing, environmental service, security, everyone gets together and we come with the blueprint. It was our job to make sure we were ready.
We went over to the outside gift shop and we found these flags that go on the car. We bought one of those. I took it home and designed it to make it into a vest.
When he came in the door, his tail was wagging, his nose was up in the air, didn't show any signs of anxiety. Once we saw the personality of the dog, we knew that he was going to be a good fit. We knew that everything was going to be all right.
Shadow came and had his vest and had his badge and came through so smoothly through security and made his elevator ride up to the floor and enter Jessica's room.
They take Shadow over to the bed and she was kind of groggy and she wakes up and she says, I love you. And she touched his head and then he laid down.
The initial meeting between the two of them was just like it was just supposed to have been that way. It was just amazing.
She was so excited and the room was so full of joy.
She was going to be able to sleep that night with that one major dream fulfilled.
It was sort of this triumphant moment of all of these things that we've done, which may seem minor, all came together in this one moment where you realize that everything was worth it to give her this incredible wish come true at the end of her life.
Shadow made a huge difference. I mean, a huge difference in Jessica. She suffered tremendously, and Shadow would crawl next to her and be a source of support. And so seeing the difference that Shadow made, you immediately knew that it was not only the right thing to do, it was the perfect thing to do.
It's hard as a physician, as a scientist, to sometimes say that there are limits to what we can do with the tools that we have. Shadow was actually almost like part of the medical team. He was able to help us give her some of that comfort and achieve more than what our medicines could offer.
Jessica knew that she was dying and she wanted to leave her parents something that they could tangibly have of hers, and that was her wish.
Shadow is playful. He loves to play hide and seek. He loves to chew on empty water bottles and make them squeak and run and slide, and it makes them laugh. There's a lot of Jessica's personality in Shadow.
It's hard to describe the love that was in the room, but you could see how much it meant to Jessica, and you can see how much it meant to her parents.
I really think that that's what this place is all about. That's what St. Jude is all about. It is certainly about finding cures and saving children, and that has to be what we're emphasizing. But at the same time, it has to be about making every day the best day it can possibly be for every child. In this case, the way to do that for Jessica was by helping Shadow come and be a part of her life. Being a part of her family for those last days of her life made all the difference. And I'm so grateful to have been a part of it.
I'm so glad I was a part of getting to care for Jessica and her family. And as we get started, I want you to think of some of the myths and barriers in pediatric palliative care and how some of those might get in the way of proper integration, even as Dr. Raj was talking about the various levels of integration. We have many barriers and many myths, and I think you'll find that they're very similar to what you have in the adult world. Palliative care, that it equals hospice, that it means giving up hope. You'll hear me share later that that is not true. The child must be terminally ill or at the end of life. Not the case. That the child must have a do not attempt resuscitation order to receive hospice. Not true. Even though I'm an oncologist, the majority of my patients who are receiving palliative care at my institution at Stanford are not patients with cancer. We also can integrate disease-directed treatment with palliative care. And fortunately, we now have very strong laws to support that in the United States. We certainly partner with the primary teams and work with them. The child does not need to move. We come to the child. We try to provide that care wherever they are, in the intensive care unit, on the hospital wards, and often in the home. The child will die sooner if palliative care is introduced. That also is not true. We will usually see that when focusing on a child's quality of life, they may well live longer. The other thing that we find is that if given the choice, not all families want to die at home. Some do want to die in the hospital. And then something that I just can't not say, opiophobia is so problematic. Dr. Raj shared how in the global South, morphine is so difficult to come by. Well, unfortunately, the opioid epidemic in the United States has worsened that problem for the global South. And it's become much more difficult now in the United States to get opioids and prescribe them properly. And so we need to be better and realize that administering opioids is absolutely essential for pain, for dyspnea, and it does not cause respiratory depression when given properly, and it does not quicken death. So when I think about pediatric palliative care and how to describe it to my colleagues, think about that. What would you all say? Well, pediatric palliative care, again, is very similar to the definition that Dr. Raj has talked to us about. It identifies and addresses suffering in children with serious illness, their families, and we help support the teams that care for them. It is appropriate at any stage of the illness and can be provided together with disease-directed treatment. Now, that's an official definition. I like to think of it as this extra layer of support. You see us as a team wearing our koala Halloween outfits. We focus on comfort and quality of life. In fact, as you see on my chest there, that selfie koala you see around me here, the koala bears, it stands for quality of life for all. That's what we're about. We work to make every day the best day it can be. As Dr. Raj mentioned, palliative care is all about addressing suffering. So the key concepts in pediatric palliative care that I think will resonate with you is that it's the total care that improves quality of life and aims at addressing total suffering. It is interdisciplinary. I know there are many people from many different backgrounds watching this presentation, and I want to again applaud the organizers for this. You can see how hungry people are to learn more about palliative care. And the many different people that are on this or in this session, I know come from a variety of professional backgrounds, and that's wonderful because palliative care must be interdisciplinary. We also have to remember bereavement support. Dr. Raj spoke to us about how healthcare is frequently destroying the finances of family. It is also very complicated in pediatric palliative care, psychosocially for parents, because if we don't properly care for their child as they're dying, they have worse psychological outcomes and in a more difficult time. The benefit of pediatric palliative care is that it has been clearly proven to improve quality of life, psychosocial outcomes, and caregiver burden, and it can reduce overall cost of care. I want to share with you a few differences, and I think these will be obvious as I'm saying them, but I think these also warrant learning more about. First, in pediatric palliative care, it is child and family centered. So the unit of care delivery actually is not very different from what Dr. Raj was talking about in India. But the unit of care delivery is not just the patient, it is the patient and the family. A second thing is that pediatric palliative care easily coexists with active treatments. And we very frequently very closely work with a variety of pediatric subspecialists because these diseases can be quite rare. And specialized expertise is important to manage complex symptoms and help define the prognosis. As a significant difference, you can see here, this is in the largest pediatric palliative care prospective cohort followed in the United States, that at 1 year, you can see here at 365 days since the point of consult, approximately 70% of the patients were still alive 1 year later. And these patients had a tremendous number of symptoms, the most common of which was cognitive impairment. So the course of illness is uncertain and can be prolonged. And the length of pediatric palliative care involvement in the life cycle of a patient, in the illness trajectory of a patient, can be quite long. In fact, some of our pediatric life-threatening conditions that we take care of in pediatric palliative care will transition. Right now, I'm in Rome. I'm speaking at the Maruzza Congress, and we just wrapped up the Congress, but this was a major point of emphasis, is how do we take care of our precious patients as they are transitioning into adult care? And the really important piece of this is that children also continue to change and develop even in the midst of their illness. So how can we best care for them? And one key foundational concept is that we must engage the child. And that when we think about communication, we must realize that we can provide good communication even to the children. But I want to challenge you and say the most important thing is to help the children feel engaged. You'll hear me talk about a concept later that Myra Bluban-Longner quoted as mutual pretense, where the children and the families are both trying to protect each other and they are not part of a shared experience. We have to understand how we can involve and engage the child. If we're going to be speaking with children directly, there are mechanisms to do so. These 6 E's, the second of which is the most important one, engaging the child. This is a significant difference in adult care and pediatric care, because in pediatrics, we must figure out a way to help that child feel a part of the care. And it's so important because communication and compassion can even impact symptoms. Over the next few slides, I want to share with you some stories about pediatric palliative care. This is my patient, Emma. She was having so much diarrhea after her bone marrow transplant, she was having to wear a diaper. I kept trying to fix her diarrhea, fix her diarrhea, fix her diarrhea, and it never helped. I never could change the course of her diarrhea. She was having 3 liters of diarrhea. But after I saw her for a few times, it was like light returned to her eyes. And she said, talking to a compassionate listener made her feel like a new person. And it was so beautiful because Emma wrote this wrote this news article with an author in the New York Times. And she wrote about this. So realize that communication and compassion can impact these young people. We have to also recognize that goals of care is a critical component of pediatric palliative care, and determining those goals. All of these are values, are backgrounds that help us understand the goals of care. And without the goals of care, we should not really be providing treatment options and decisions. And unfortunately, as Dr. Raj has said, too often we do because we can, not necessarily fully contemplating if we should. And also, a choice is only a choice if it is indeed a choice. And very frequently, we put the weight of decision-making on families here in the United States when shared decision-making was not necessarily warranted because there was such a clear choice to be had. Hope is essential. Hope is essential because it is the thing with feathers. One of my precious patients who was undergoing a bone marrow transplant, it was experimental bone marrow transplant. I walked into her room and this was written on the window. She stood in the storm, and when the wind did not blow her way, she adjusted her sails. Hope anchors the soul. These children, just like the adults you're caring for, hope gets them through the day. I asked her what she was hoping for, and this is the other interesting thing she told me. She said, Dr. Baker, I know I am going to die from my leukemia, but I'm hoping other children won't have to die from theirs because I have enrolled in this clinical trial, and I hope to teach people how to better treat my leukemia. That's incredible. The other interesting thing that we have determined is that hope can be held by parents even at the end of life. They can hope for cure and recognize their child is dying. As this father told us, partner with us and witness the transformative love of hoping for the impossible and the improbable while accepting the painful reality that our rare and beautiful child is gracefully exiting this world. We also have to help families and help children think about opportunities for legacy. And we need to overcome mutual pretense. We need to, again, help engage the child and help the children think about their last wishes. A precious patient I cared for, I asked her, what are you hoping for? And she told me, I'm hoping to see my little sister born. And she had a terrible tumor in the back of her mouth, and we didn't think she was going to make it, but we decided to place a tracheostomy. And here she is holding her little sister in the delivery room. But even more so, you can see her here holding her little sister at home. Or my patient in the middle, who it wasn't his birthday, but he definitely wanted to have a party. And it had to be the Minions. And this is a delicious chocolate cake in the middle. Or my other precious patient who, when we asked her what she was hoping for, she said, I want to create songs for each of my loved ones. And this is a song that she made for her mother with our music therapist.
I found a love for me. Darling, just dive right in and follow my lead. Well, I found a girl, beautiful and sweet. I never knew you were the someone waiting for me.
Can you imagine if her mother did not have that recording? It is such a beautiful recording, such a beautiful memory. Unfortunately, we find that clinicians frequently stand in the way of pediatric palliative care integration. And a study that we were able to conduct demonstrated that families and even patients are willing to see pediatric palliative care right from the beginning of the diagnosis of their serious illness. And we have to recognize that unfortunately, it is the healthcare system regularly that stands in the way. And so as I close, I want to share with you many of the similarities and highlight a couple of the differences. Suffering is the disease that we treat in pediatric palliative care, much as Dr. Raj described to us as palliative care in general. Integration is essential. Again, I'm so grateful to have been able to share this stage with Dr. Raj because he speaks of integration at the country level so beautifully, and we must recognize that integration is key. Communication and engaging and involving the child. I hope that you've heard and I've demonstrated how essential that is and how critical empathy and relationship-based care is. We must recognize that end-of-life care is an emergency that we must be planning for, and we have to think about opportunities for legacy for these children, for these families. And frequently, if we don't do this, if we don't provide appropriate anticipatory guidance, families will have regrets. I want to also make sure that people recognize that when a child dies, it is devastating, and grief and bereavement is an essential component of our programs, and we must advocate for strengthening grief and bereavement outcomes. And then, much as Dr. Raj has shared with us, access to high-quality pediatric palliative care is a fundamental human right. And I want to encourage you, because you might say, I'm not sure how I can care for these kids in the best way possible. But the answer is, open your heart to them. Attend to the suffering through early integration, a humble curiosity, and holistically providing compassionate care. Thank you so much. I'm so grateful to be here with you by Zoom. I am certainly hoping to be there with you in person at the next Congress. I would encourage you to join our global community. You can take a picture of this QR code, and then we will send you resources, and you can be a part of our global pediatric palliative care community. Thank you so much.
Thank you so much, Justin. That's really excellent. I was constantly wiping my eyes. This is why I can't do pediatrics. We're going to move on to the last session for the morning, or the initial session. And it is my honor and privilege again to welcome onto stage Professor Humaid Al-Shamsi. Humaid is a very close friend and colleague, and Humaid is the reason I'm even working here in the UAE. So Dr. Humaid is a medical oncologist with almost 20 years of experience. Initial medical training was in Ireland, followed by subspecialty training, all in Canada, correct? Yeah. He did his subspecialty fellowship in GI and palliative oncology. He's the president of the Emirates Oncology Society and has extensive clinical and research experience in solid malignancies. And he is clearly a strong advocate for palliative care here in the UAE. So he's going to give us a little bit of know-how about what we ought to know given the rapidly changing landscape of cancer treatment. All yours.
Thank you so much. So, assalamu alaikum wa rahmatullahi wa barakatuh, and thank you for this conference, Dr. Neil, and I would like to welcome Dr. Sousan, who is the head of the Friends of Cancer, and October month is a very busy month for them. So thank you so much for coming, and I would like to welcome everyone coming from across the region. And Dr. Neil, it's not fair to put me after all these two amazing talks, but I'll try to make them interesting. Because I have only 10 minutes left until the official opening, my talk is supposed to be 20 minutes, so I'll be skipping throughout. Clicker. So in the next 10 minutes, I will highlight what are the important aspects for healthcare providers working in the palliative care they need to be aware of from oncology perspective. I'll be skipping slides, so it's okay. I'll be talking about precision medicine from screening, genetic testing, understanding mechanism of action for targeted therapy, immunotherapy, and how immunotherapy has changed the way we treat cancer. Also, the evolution of radiation therapy, chemotherapy, immunotherapy combination, oncological surgery, PIPEC surgeries, oncology drug costs, and also a new concept that's growing called common sense oncology, which we have to rethink when it comes to goals of care that Dr. Justin was talking about. So the precision oncology and medicine actually is moving forward now, since we're talking about prevention and early detection. Early detection is very important to be able to cure these patients from cancer. We do want to treat patients with advanced cancer. We'd like to see this patient with cancer early stages so we can cure them. So this is a very interesting study looking at the Pathfinder, looking at the use of ctDNA as a screening modality for patients with no cancer or maybe just some risk factors. And this is actually evaluating patients over the age of 50 and looking at the ctDNA. Special ctDNA, I don't want to go to too much details, but it's designed to evaluate different malignancies. And the median age was 60s, and out of 6,000 patients, they could detect 92 patients with some signals indicating some malignancies. The median age to confirm cancer was around 57, but also to exclude cancer was longer, was 162. So once you have a positive test, it took them longer time to exclude cancer. They were doing more tests to exclude cancer. And they found 19 solid tumors and 17 hematological malignancies. And the test has specificity up to 99%, and the negative predictive value was 98%. So there's a test that's still in clinical trial looking at the use of ctDNA as a screening tool. There's actually another test in UK called Galeri, which is running actually a very large clinical trial, more than 140,000. And the point is there are ongoing interest in ctDNA as a screening modality for cancer, and I'm sure we'll be hearing more and more about it in the next few years. Currently, there is one test called Shield, which is actually approved, available in UAE as well, which is used only for colon cancer screening. So it's only for colon cancer. The other previous tests I was talking about, they were looking at 50 plus different types of cancer. It was multi-cancer screening. So currently, we have only the colon cancer FDA approved from Guardant, but certainly that will be seeing more and more tests available in the future. Moving now to diagnostic test, I was talking about screening. Now I'm talking about ctDNA as part of the evaluation of patients with cancer. And actually, this is a growing field, and we're using this currently in practice. And the whole idea is when you do a CT scan or a PET scan, you cannot see the cancer, and you can tell the patient you're cured. But the reality is when you do this test, you can see that this patient actually is still positive. So for this patient had a colon cancer. He was cured, but when we did the test, we found that the patient was actually positive ctDNA. We gave them chemotherapy, and after a time that you can see the patient actually is negative. So this is a very important tool for us to help us to cure these patients. What we use now is to use it to escalate treatment. That's if the test is positive, I will give more treatment. If it's negative, it does not mean that I will stop. I need to give them also treatment because we're still trying to learn about how to use ctDNA in the setting. This is another patient as well with a positive test, treated and became later negative. This is another patient, fortunately, was negative. Even the CT scan, PET scan was negative. The patient showed some positivity. After some time, the patient showed that they have disease on the imaging. Sometimes we have difficulties, the amount of disease available and the ctDNA not enough, so you have to repeat the test a few times. This is another test we use for a patient with breast cancer, and we found this patient have positive genes called ESR1, so we use a different medication called Illustrant. And again, no biopsy, just from the blood, we can diagnose, we can treat, and the field is still growing and moving forward. Genetic testing, I will just skip this part. The bottom line is there is ongoing discussion how far should we test these patients for genetic or gene mutations. Currently, the discussion is we have to be selective when it comes to test these patients. But the reality is there is more interest nowadays to do universal testing. Actually, in my practice, I do universal testing because I know it does make a difference. In this cohort study, you can see the blue color are the patients actually who are meeting the criteria for testing. But the red color ones, actually, they are not meeting the criteria and they're still positive. So we are moving more toward universal screening in the future. So what about understanding the mechanism of the targeted therapy? And this is the third point I would like to bring to you guys. Targeted therapy has evolved the way we treat cancer. In the past, we used only chemotherapy, but targeted therapy has been evolving, and there are different mechanisms for action, which I'm not going to go through, but certainly targeted therapy has transformed with the way we treat cancer. For example, imatinib was the first treatment targeting CML, chronic myeloid leukemia, and transformed the way we treat cancer. Patients are treated now as a chronic disease like diabetes. They live normal life and also normal expectancy of life with a simple medication because it's targeted therapy. There's a huge list of targeted therapy, and the field is still evolving, and certainly the targeted therapy has transformed the way we treat cancer, especially lung cancer, CMLs, and other cancers. In fact, the survival also has improved with these targeted therapy. Tissue agnostic therapy, it's a term you have to use if you want to look fancy nowadays in oncology. And the point is that you're targeting a specific mutation, not disease. And in the past, we used to talk about targeting non-small cell lung cancer, but using tissue agnostic therapy, I'm targeting a specific mutation. And the first approval was for pembrolizumab for MSI-high cancers, and certainly this has transformed also the way we think about cancer. We're not thinking about disease specific, for example, lung, we think about specific mutation. What about immunotherapy? Certainly, immunotherapy also has transformed the way we treat cancer. In the past, we used to talk about surgery, radiotherapy, chemotherapy, but now immunotherapy is making a huge difference in the management of cancer, including checkpoint inhibitors, cell therapy, cytokines, treatment vaccines, and also oncologic virus therapy. Indications are over the place, including head and neck, breast cancer, lung cancer, and certainly this is making actually a difference in the way we treat, and also to be successful in treating cancer. CAR T-cell as well has been approved in different indications, including multiple myeloma and diffuse large B-cell lymphoma, and also ALL. Toxicity is different. You don't need to worry about this, but you should know that toxicity for immunotherapy is completely different, and you have to be aware of it, and also you have to think about it, because certainly it can have also serious side effects. Radiotherapy, I'm not the right person to talk about radiotherapy, but certainly that radiotherapy has evolved over the last few years, including IMRT, including IGRT, and also SBRT. But certainly that also, the SBRT also is helping us a lot to treat patients with oligometastatic disease, which means only few sites of metastasis. So we can still treat these patients with curative intent. In the past, we were always saying that these patients are actually metastatic. We cannot treat them, but certainly we are considering these patients actually for curative intent, even if they have small volume disease, including SBRT. And proton therapy as well does have a role. Unfortunately, we don't have it in GCC because it's complex, very expensive, and you don't have high volume patient, but it's available in India and other places, including US and Europe as well. Combination chemotherapy and complex is the 7th point I would like to bring to you guys. In the past, we used to use chemotherapy alone or immunotherapy alone. Currently, we're using actually combination of chemotherapy and immunotherapy. And again, this has actually shown to improve the patient outcome, especially when it comes to lung cancer. There's a huge list of indication currently for non-small cell lung cancer and other gastric cancer and triple-negative breast cancer. So we're using now combination of chemotherapy and immunotherapy, but definitely this is causing more toxicity. At the end of the day, these are tools we're trying to come up with the right protocols so we can help our patient in a better way to reduce the risk of recurrence and also to cure them. Robotic and oncological surgeries, another point that I would like to bring up to your attention. The robotic surgery actually has been improving the outcome for our patient when it comes to more precision, minimally invasive, improved outcome, and also cosmetic. And certainly the indications are huge, including prostate cancer, kidney cancer, bladder cancer, and also pancreatic cancer. The only thing I would like to bring to your attention is breast cancer. Unfortunately, some are advocating or advertising to use robots for treatment of breast cancer. Unfortunately, this is not approved yet. Even the FDA actually did not grant and has a warning against the use of robotic surgery in breast cancer. This is the only indication that we don't, promote for right now, but certainly that, this may change in the future. PIPIC for advanced peritoneal cancers is another thing I would like you to be aware of. And actually, it's very helpful in the setting of palliative care for patients with heavy metastasis. In the past, we used to think about HIPIC, which is the clearance of the peritoneal disease and then washing with chemotherapy. But PIPIC is indicated for patients who has a high BCI, high volume of disease. You cannot resect, but you can also use this, pressure inside the abdomen, where you can put pressure with chemotherapy, and this actually can be used as an adjunct with chemotherapy to improve the control of cancer. This is not curative. This is palliative, and that's why Dr. Justin was talking about we have to be very clear with our patient regarding the aim of the care. What's the goal of the care? We have to be very clear from the beginning. Are we trying to cure or we're trying to palliate? And again, PIPIC is not a replacement for chemotherapy. It's an adjunct treatment in conjunction with the chemotherapy, trying to control the disease for some time. Ongoing trials, many trials, but the bottom line is it does have some signals. It's not approved yet. Many centers are still not using it, but certainly it's a tool that you have to keep in mind for patients, especially with GI cancers, ovarian cancer, that are desperate and they need some help and support. Increasing cost of cancer drugs is a global phenomena that we're facing, and unfortunately, when we look at the average cost, for example, in the U.S., it's around $200,000 per year. And you can see the cost is growing over the years, and this will not get any better. So that's why you have to think about the last point, which is common sense oncology. We have to think about what's the point from treating this patient? Are we trying to cure this patient? Are we able to afford this? This is a global movement about trying to understand how much difference are we making the patient's outcome when it comes to using modern medications, and the movement also trying to put some guidelines to try to address the challenges when it comes to the cost associated with the newer drugs. So these are the 10 updates. I hope that it was useful, and I would like to encourage you and invite you to look at our two posters from our students who are actually coming here from MPRU. This is their summer projects. We have two abstracts regarding the cancer, so palliative care in UAE from public perspective and also from patient perspective. So please join us and you can have a discussion around these posters later on. And I would like to thank them for their work and their efforts during the summertime. And also I would like to announce the palliative care in the Arab world, which is also sponsored by Barjir Holding. This book actually in the final phase. And I would like to invite Dr. Raja to write the foreword for this book. We'll be in touch with you to do that. And with this, I would like to thank you for your attention. Assalamu alaikum wa rahmatullahi wa barakatuh.
Okay, so I'll invite Dr. Raj and Professor Hamed onto the stage. We'll take a couple of questions, but we need to make up some time because we started a little bit late. If there are any questions, can I just get you to use the microphone stands at the front? Any questions? Are we all being shy? Anyone? Okay.
Neil, over here.
Okay. Is Justin online? Micheline? Justin is still online? Oh, he left. Okay.
Oh, the question was to Justin, so
Sorry.
sorry for that.
That's okay. I think I might have a question just because the first two sessions were really sort of quite illuminating. We have this, I think some of us might know Christian Nzira from Rwanda. He has this concept of sort of safari palliative care. And one of the things he mentioned is that, you know, when you are well and in good health, you make your own decisions. However, when you become unwell and you become sick, you now belong to the family. So the decision making is somehow taken away from you. This is something we see quite a lot in the UAE. This is directed to Dr. Raj. I'm just wondering, do you see this phenomenon a lot in India? Or do the patients generally have more autonomy about the illness?
All the time. But I must also point out the cultural difference in the exercising of autonomy. In the Western culture, it's more of individual autonomy that's paramount. Whereas in maybe in the global South, it is collective autonomy that becomes equally relevant. This is my life, but this is also Chandriya's life. And that cultural thinking, unfortunately, seems to have a negative connotation in this context. I am powerless. Everything is taken away from me. From the point at which I am unable to raise my voice and speak for myself. Huge problem.
Huge problem.
Need?
Yeah.
Question?
Please.
Yeah, so I have a question for Professor Hameen. So as a president of Emirates Oncology Society, which harbors palliative care, radiation, and all the kind of cancer tackling thing, we understand that one of the things that patients suffer is, continuing giving systemic therapy or aggressive therapy, and the patient's kind of dying within a week or two. I believe that one of the KPIs now for a lot of hospitals and cancer centers is, when was the last chemotherapy given, and should be not less than, X number of weeks. Can you please elaborate on that? Is there any potential rule or law that we are going to be implementing where to really care about this for the patients? Thank you.
Thank you, Dr. Ibrahim. This is very important. In fact, last weekend I was in Ireland and I had a few friends, and one of the friends said, she's an anesthetist, she said, you doctors, you only give chemotherapy until last day. And I said, you know what, this is actually not true. In fact, we advocate many times stop treatment. And that's why, Dr. Dustin's talk was really, touching for me, because it's about goals of care. When should we stop? When should we say no? When should we tell the family and the patient, we have to stop now? And this is something maybe we don't do very well. Sometimes we are shy. Sometimes we are trying to keep them happy and just keep going. And again, as you mentioned, there should be a KPI. As you are part of the UAE National Cancer Committee, we've been talking about how to improve the cancer care in UAE, and Dr. Niels also knows this. We've been talking about having, very clear KPIs when it comes to palliative care, and one of them was actually when to stop treatment. Giving chemotherapy in the last 2 weeks, or even, in fact, I think even 1 month, is not something we should do. We should advocate for stopping treatment when we believe that treatment is not going to make a difference and in fact may be harmful. It's a very difficult situation we face on a daily basis, but again, increasing the awareness of the public about when to stop treatment and the importance of focusing on symptoms control and palliation, it's something we have to work on.
Any other question? I just have one more. I'll be a little bit selfish. This is something that I struggle with a lot. especially here in the UAE, a lot of families say, "Doctor, you can't tell mum, you can't tell my grandma. You'll take all the hope away." So I like Justin's comment about hope anchoring the soul. And I think that is true, but hope is also dynamic. You know, what you hope for today is not what you hope for in 2 days' time. My feeling is that actually, unless you have an honest, open conversation with somebody, you won't know what it is they hope for. So how can you possibly talk about hope if you're not honest with the patient? Any comments on that, Dr. Raj?
Thank you. Again, such a huge issue. I spoke about collective autonomy. The patient is not coming to me for treatment. The family is bringing the patient to me. And if I say, no, he has a right to know, I must tell him, then the family just simply takes the patient away. Now, the problem is very often we see this well-meaning family member as an antagonist. It's like at a game of tennis. I explain, he has a right to know, but he will be destroyed if he knows. But if he has a right to know, we have to tell him, no, you are being cruel. The trick is to recognize that he is not an adversary, but somebody we should be working together with. The trick is to jump over that net and go to his side of the court. I will have to sit down. I will tell that son or daughter. I won't start an argument. I will say, you love your mom very much, don't you? I can see it in your eyes. That moment, we are on his side of the court. It's going to take time. It's not going to happen today. But if nothing seems to work, I'll bargain with the person. I will say, okay, I will not tell her anything today, but please give me permission to ask your mom what she knows, what she understands, what questions she has. After that, I'll come back to you. We'll talk it over together. But somehow, we have to negotiate. Otherwise, we lose the opportunity to help the person.
Agreed. I think Aftar was first, please.
Sir, Raj sir, question directed to you. So we talk about patients who are on palliative care and end-of-life care, but there are other who live alongside them. We call them invisible patients. Can you please share your views on invisible patients?
Thank you. I apologize. I should have mentioned them. The loving family members often suffer as much as the person and sometimes more. We look after people with paraplegia, usually young men, motorbike riders or a fall from height, very often with a young wife and one child or just a wife. And what kind of life is left for that woman whose whole life becomes having to take care of this one person? And in a joint family, often snide remarks. When she came into this family, everything happened, kind of thing. I've had 2 young women, wives of paraplegic people, killing themselves. One had a small child. Their depression will never be detected. We may diagnose a depression in the patient, but not in the invisible patient. Thank you for bringing that focus. In our unit, our initial patients chart has a column for the caregiver's health status and their problems.
Thank you so much. Dr. Zainul.
Professor Dr. Rajagopal, I'm Dr. Abidin, pediatric oncologist working in Burjil Holding. I'm from Calicut Medical College also. So, in UK, when we start treatment in pediatric oncology, we involve pediatric palliative care consultant at the start. But one of the challenge here is even we can't see any pediatric palliative care specialist. So what is your opinion and what is what do you see the challenge of developing pediatric specific palliative care support? And question to Professor Humaid, is the leading person in cancer in UAE and Middle East. What is your strategy in developing pediatric palliative care in UAE?
Thank you. Imagine a village where there is poor access to transport, where one doctor looks after everything. Whoever is available takes care of any illness. Similarly, all our palliative care educational programs, nurses, doctors, physiotherapists, common people, they include management of children. So a doctor who is trained in palliative care should not make it an excuse to say, no, I have had no training in pediatrics. Therefore, rejected. Not possible. That's unethical. Secondly, yes, so vitally important specialty. In our country, about 4% of people have access to palliative care, but less than 1% of children have access to palliative care. It is that bad. Thank you for highlighting that.
Thank you so much, Dr. Zain Al-Abidin. In fact, we're already trying to tackle this by hiring someone who's trained in adult and pediatric. The problem by hiring someone who's only pediatric palliative care, the volume of patients is small, as we all know. The number of patients in UAE is very small overall for pediatric oncology, hematology. So if you hire someone, you have to make sure they're able to use their skills and knowledge. So we try to tackle this, Dr. Neil, by hiring someone who covers both adult and pediatric. Again, I'm talking about the level of our Burjeel holding, but certainly there is a need for more pediatric hematology, oncology, and also pediatric palliative care physician in the country, and this is something certainly that we are bringing up to the Ministry of Health in UAE as a part of the UAE Committee for Advancing Cancer Care. Palliative care, actually, one of the top priorities that we've been discussing with them, trying to make sure that it's addressed and also being put in the spotlight so we can advance at the level for pediatric and also adults.
Okay. All right.
Thank you for the excellent session. So how do we exercise the autonomy of the patient at the terminal stage? When we discourage the end-of-life care, are we discouraging the hope of the patient? Sometimes.
Hope is essential, but it has to be realistic hope. You give false hope, and when it's crushed, the patient is destroyed. There is nothing else to fall back on. I had this young woman, not a 42-year-old woman, whose one wish was to see the grandchild, which was not going to be possible. Her time was very close. Hope shattered? Not yet. What we helped her to do was to create a series of videos of she talking to the unborn child. One to be brought out when the child was 3, another at 5, and so on. And she put all her life into the creation of those messages for the unborn child. You look at the best possibility that's realistically possible and build hope around them. The only thing is, when we make promises, we have to fulfill them.
Thank you.
Thank you so much. I think we're going to hold questions now just to catch up on time. So I'd like to thank Dr. Raj, Dr. Humaid. You're very welcome to stay on stage if you like. Yes? You can stay on stage. Round of applause. Oh, they have to come off? I stand corrected. You have to come off the stage. Thank you so much. So I can do my thing? Sorry. I can start? Okay. All right. So Thank you guys again very much for coming and giving up your very, very precious weekend. I really would like to say thank you so much for coming. So formal invitation or formal opening, distinguished guests, those who've traveled from abroad, colleagues, presenters, Her Excellency, Mr. Sausen, who's the founding member and president of the board of Friends of Cancer Patients, Dr. Rajagopal, who's made his way all the way from India, Mr. John Sunil, CEO, Burjeel Holdings, Professor Hamed, and all of you, thank you so much for coming and showing your commitment and demonstrating interest is perhaps an understatement, but interest in palliative care. I think I got to the UAE, to Abu Dhabi in early 2020. The reason I'm here is because Burjeel had a vision for providing comprehensive cancer care. They also had the vision, singularly, to realize that you can't provide comprehensive cancer care without providing palliative care. So these two things go hand in hand. And if it wasn't for Professor Hamed reaching out to me while I was at a conference in Spain, saying, are you still interested in working in the UAE? Okay, fine, hang up the phone, somebody will call you back. So this was way back in 2019, and this is why we are here. So I'm eternally grateful. I'm so grateful that we've had the opportunity to actually host a palliative care conference. Palliative care as a specialty has been extremely underrepresented. It's always been there in the background, but it's like many things that are sort of viewed to be taboo or unspoken of. The only way to make these things more mainstream is by being open and speaking about them. So for me, in my own humble little way, having a palliative care conference, the first one in the UAE, to me signals a transition of palliative care moving into mainstream consciousness in medicine. So I'm so grateful. So thank you guys very much for coming on a Saturday morning, and thank you for your support, for sharing our commitment to compassionate care. So to formally start the opening of the conference, I'd invite you to all stand for the UAE national anthem, please.
Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Neil. And I would like to thank again everyone coming from across the region to join us today. I only have a few slides, and I would like to say that we came a long way from the first time we started talking about palliative care in the UAE. It's not working. Just a second. Yes. So my first exposure to palliative care was back during my fellowship in oncology. And when we were using actually a transition patient from oncology to palliative care, I felt there is something wrong, because I felt that, getting rid of our patient, we are just telling them, good luck, you have only a few weeks left, you'll be dying, you have to go to palliative care. And I just feel that, this is not right. We should be, as a physician, as an oncologist, we have to be with the patient from day one. We have to be providing them with the palliative care, supportive care from day one. And this actually something was not very clear at that time. It was back in 2010 when we started to have evidence supporting that patients who are getting supportive care and palliative care early, they live longer. And we started to appreciate that, this is very important, not about giving the patient treatment, but also trying to reduce their symptoms, trying to reduce their suffering. And this actually can have a physical impact on these patients, and they can live longer. That's why I decided to do an extra year of fellowship in palliative care. And in fact, if time goes back, I will still do it because it does give me tools, understanding, and also skills to help my patient, not only at the end of their life, but also every single day I see them when they have symptoms, they have nausea, vomiting, severe constipation, they have pain, I can take care of them. And I do believe, as Dr. Raja said as well, it's a very important skill for every patient, for every physician, not oncologist, but every physician that's taking care of patients. The first publication about palliative care in UAE was after I came and I found out that, the first time I remember I prescribed hydromorphone in one of the hospitals, and I was told, "Doctor, what's this?" I said, "It's a medication for pain I needed for a patient who failed morphine." They said, "Actually, this medication not available in the country." I said, "What do you mean by that?" I said, "It just doesn't exist." So it was just an eye-opener for me that, it's not only about the skills and the knowledge, but also about the tools available for us. So we started to work together, published the first paper with our friend Dr. Muna Tareen, who's currently clinic, trying to understand the challenges that we have in cancer care when it comes to palliative care. And this actually was the paper, me and Dr. Neil, we met online through the email, and then we started to communicate. From there, we went actually to become, the first ISMO accredited center for oncology and palliative care. And this is another milestone for us, trying to put the UAE on the international map when it comes to the palliative care. And then Dr. Neil became the first representative in the WHO Palliative Care Network. And again, this is very important to establish a network with the international community, trying to come together and have a proposal to improve the cancer care in the country. We established the Palliative Care and Supportive Care Working Group under the Emirates Oncology Society. And again, this is also to bring together all the palliative care physicians across the country, trying to, again, work together. Unfortunately, the healthcare community in UAE tends to be more competitive, but under the umbrella of the Emirates Oncology Society, we try to bring everyone together, trying to work for the best of for the care of our patient, regardless where you work. Also, as I mentioned earlier, we are part of the UAE Ministry of Health National Cancer Committee, and we do put palliative care actually. Every time we bring it up, as this is important. We have to establish the palliative care services across the UAE. And in fact, also at the level of our Burjeel holding, as we try to push the envelope, and there's also more recently collaboration with St. Christopher Hospice, trying to bring this concept to the country and to the region as well. We're very proud actually to provide the first palliative care service in Northern Emirates with Dr. Neil, who travels all the way from Abu Dhabi to Northern Emirates in Sharjah, which is around 2 hours away. We provide unlimited consultation for patients without any insurance. Again, we couldn't do this actually without the support from our Burjeel holding leadership, because they believe every patient should have an access to care. We cannot give treatment for free, but at least we can give them recommendation where to go, what are the medication they need to improve their skills. And to be honest, this is something we're very proud of, because this is the first palliative care service in Northern Emirates, and we're seeing many patients every week just to get the care they need. And again, moving forward and reaching this level for palliative care in 2020 here today is a huge milestone for us. And with this, actually, I would like to thank everyone contributed. I would like to thank Burjeel Holding for sponsoring this. It was very difficult to get sponsorship from the pharma industry, because, again, palliative care is something maybe not that important, but it's very important. And only those who are affected by diseases and suffering will appreciate how important palliative care is. With this, also would like to conclude with the palliative care in the Arab world, which is coming up in the next few months. This is an effort for a long time now, and myself and Dr. Neil actually are the editors. Why does this keep going off? And we're very proud to make this also open access supported by Burjeel Holding. And with this, I would like to thank you for your attention. And I would like you to, I wish you, inshallah, 2 exciting days, knowledge, experience, and always remember, palliative care is a must for every physician, no matter what specialty you do.
Assalamu alaikum. اسمي سايمون بوعز. عندي 46 سنة وأنا إنجليزي. بحكي شوي عربي. يعني أنا ساكن في فلسطين. أنا درست في فلسطين وشغلت في فلسطين. درست في جامعة بير زيت. يعني بحكي شوي عربي بس مش كتير. بس أنا بحب اللغة العربية. بحب الناس عربي وقلبي نص فلسطيني. I used to say that I hope I get hit by a bus and never know anything about what's going to happen. But having these last few months at home in peace and comfort have been wonderful for me. And I've been trying to reflect on why I'm in such a good mood. I'm going to die very soon. The calcium levels in my blood are what's going to kill me. And none of the drugs work for that anymore. And that's probably in the next 2 weeks or so. So by the time you're watching this, I'll have been gone for a while. It was terminal, and I discovered that a couple of months ago. And I took the decision. They always say there's more chemo that can be done, more clinical trials, but I took the decision with doctors' approval actually, that more chemo would only buy a couple of months, that it makes you feel terrible, it really does. And that also it increases your risk in some ways of dying in an unpleasant way, perhaps from sepsis or in hospital, not knowing what's going on around you. And I thought I'd actually like to spend a couple of months feeling pretty good, as I do, thanks to the palliative care teams, with my family and just learning to accept what's happening. The palliative care teams have been wonderful, and I couldn't have done this without them. They treat me and not my cancer, which is such a difference sometimes from the medical teams, who will always have some last line of something. But palliative care has kept me out of hospital and treated my pain and my symptoms and let me keep doing the things I love with my wife and my family. They've even helped me have time to write a little book about my situation, which is called A Beginner's Guide to Dying. So it's a stupid title in a way because we're all beginners at this. And then therefore, how can I write a guide? I'm a novice. So I'm so glad to have the opportunity to make a video for your conference. I'd like to thank Dr. Neil and others who work so hard developing palliative care. And I very much hope that in your region and in other parts of the world, it can start to bring the advantages that it's brought to me. So thank you very much, and I wish you all the best. Thank you.
Excellent. So lots of videos today. So I'd just like to say a few words. So I met Simon virtually quite a few months ago, and we kept in touch, and I mooted the idea of coming and sharing his experiences at the conference. And he said, listen, that'd be really selfish. I'd love to do that. But mate, I don't think I'll be alive in time for your conference. So the next best thing was to make a video. And really, it's his attitude and his approach to dealing with mortality and being able to focus on what's important that was so nice. So I'm so glad we had the opportunity to have his video. So at this time, I would like to take the opportunity to honor some remarkable colleagues for their contributions, specifically to healthcare and to cancer care. And to do that, I'd like to invite my colleague, Mr. John Sunil, to come to the stage along with Professor Al-Shamsi, please. So first, can I please ask to the stage Her Excellency, Mr. Sausen, come on stage. Sure. Will do. Next, can we ask Dr. Rajagopal to make his way to the stage? So just a few more things to talk about. So we're very, very happy and privileged that Dr. Rajagopal is gracing us with his presence. And he will also be, after the opening ceremony, during the coffee break, signing copies of his biography, Walk with the Wary. So we're very, very honored to have this. There was one more slide. Next one, please. I think Dr. Humaid has already sold this, but they were very, very proud that there's a dedicated palliative care in the Arab world book coming out next year. We have tried very, very hard to include all the Arab countries, so this has been a labor of love, a lot of work, but we're looking forward to releasing this, and this will be completely free, downloadable as well. Thank you. And one more slide. Excellent. So a few days ago was sort of, ICPCN. It was a campaign for children's palliative care. Hats off for palliative care. So we actually have a stand outside with lots of very, very cool hats. We'd invite you to, during the break and throughout the day, to please go put on some silly hats and have your photograph taken, just to demonstrate awareness. And we will post this on all the socials. And then the very, very last thing for the opening ceremony, I'd like to invite our students from MBRU to come up onto stage for all their contribution. And I think this was probably the first survey of patients and families regarding awareness of palliative care. So sterling, innovative work. I haven't seen it. Fariel, are you around? Please. So Fariel has been instrumental in the majority of the research work in Brazil. All the publications would not have happened without Fariel's help. So thank you very much. So before everybody runs away for the coffee break, can we please do a group photo? Can we have everybody on stage, please? Everybody's invited, please. Come on. I don't want to have to run around with a stick. Come on.
thank you so much for inviting me in to join your
Each of us has a story filled with chapters. We were at the peak of happiness. Everything was going well. We're spending our summer vacation after a year filled with professional achievements. And most importantly, we're eagerly awaiting our firstborn. Oh my goodness. We didn't know that our routine visits to check the baby's health would mark the end of one chapter and the beginning of another.
Can you see the spine? Basically, the lower part of the spine is not closed. That means that the spinal cord here is completely exposed to the fluid around the baby. It is pulling the brain down, preventing.
We discovered a problem with the baby's spine and spinal cord. We were placed with many options in front of us, and we needed to pick the lesser evil out of them.
When I met Mary and Carl, they were aware of the options of either ending pregnancy or continuing pregnancy, with the consequence that this baby will be born, possibly not be able to walk for the rest of its life. We discussed the option of repairing the spina bifida inside the womb.
We had to make a swift decision. Returning home was not an option due to the risks it posed to the baby. We won't terminate.
So spina bifida is a common neural tube defect in which the spine fails to close completely. I'm just going to take the incision on the uterus, hold the baby. It's a very complex procedure and we're completely aware of the risks. It becomes an emotional responsibility to ensure that I deliver the best care. So Mary once jokingly said to me, do you ever sleep? Because whenever I text you, you're always there on your phone. And she just texts me. Shall we go and see her and her baby?
Yes, yes, of course.
Perfect, come.
Nestled within Burgio Medical City, the Kypros Nikolaides Fetal Medicine and Therapy Center proudly stands as the first of its kind in the Middle East and North Africa. Our center specializes in precise clinical diagnostics, aiming to detect and diagnose fetal anomalies as early as 14 to 16 weeks. With state-of-the-art technology, we are pioneers in performing in utero spinal cord repair surgeries, setting new benchmarks for fetal care in the region. At Burgio Medical City, our dedicated team is committed to offering expecting parents the best options and striving for the healthiest outcomes for their growing families. Because every new life deserves the finest in fetal medicine and compassionate care. BMC, Burgio Medical City, getting you ready for life.
At Burgio Cancer Institute, we offer a full spectrum of oncology services, including early detection, advanced diagnostics, radiation and surgical treatments, and palliative care. Our success rates stand shoulder to shoulder with the world's leading institutes. With cutting-edge technology and a commitment to personalized care, we've made substantial strides in enhancing patient outcomes and quality of life. Burgio Medical City is also proud to feature the ExactTrack dynamic treatment technology. This innovative system allows for real-time patient positioning and monitoring, integrating surface, thermal and X-ray tracking with sub-millimeter precision. We also offer pediatric radiation therapy and meticulous bone marrow transplant planning. with the latest body irradiation techniques. Our expert team works in close collaboration with renowned regional and international centres. This technology is integral to our advanced radiotherapy programme, enabling our specialised staff to deliver unparalleled cancer care with state-of-the-art tools. Because every journey towards a cancer-free life deserves the utmost in oncology care. BMC, Burjil Medical City, getting you ready for life.
At Burjil Medical City, we lead the way in paediatric orthopaedics, handling complex cases with exceptional success and minimal complications. The Paley Middle East Clinic stands at the forefront of innovation, offering groundbreaking care throughout the region. Our mission is simple: to transform young lives through cutting-edge orthopaedic solutions. Whether addressing congenital issues or post-traumatic conditions, we excel in limb lengthening, deformity correction, and more. Committed to reconstruction over amputation, our expert team delivers personalised care tailored to each child's needs. We have achieved a remarkable reduction in complications for children with congenital, growth-related and post-injury conditions, enabling them to thrive and lead fulfilling lives. Because every child embarking on their journey deserves the finest expertise in paediatric orthopaedic care. BMC, Burjil Medical City, getting you ready for life.
At Burjil Medical City, we are at the forefront of robotic surgery, leveraging cutting-edge technology to handle over 80% of surgical procedures with unparalleled precision. Our specialists use the state-of-the-art Da Vinci Xi surgical system, enabling complex operations with exceptional accuracy. This advanced technology provides 3D comprehensive vision and highly dexterous robotic arms, ensuring surgeries are performed with supreme precision, care, and efficiency. Patients benefit from minimized surgical intervention, leading to quicker recoveries and shorter hospital stays. Plus, Burjil Medical City offers extensive rehabilitation and physiotherapy services to support every step of your recovery journey, because every surgical journey towards a better life deserves the pinnacle of precision and care. BMC, Burjil Medical City, getting you ready for life.
Mariam worked hard to establish her company, and the idea of giving up never crossed her mind. Every moment was crucial in bringing Mariam back to her life and her work. Our medical team at Burjil Medical City knew that Mariam's case was sensitive, especially since the type of cancer she had was rare and needed to be addressed as quickly as possible. For this, our specialists in gynecologic oncology relied on minimally invasive robotic surgery to remove the cancerous tumor, ensuring high precision, reduced pain, and rapid recovery. After comprehensive analyses and examinations, we scheduled Mariam for advanced radiation therapy sessions to eliminate any remaining cancer cells. The moment Mariam re-entered the company premises is one that no one will ever forget.
Hello.
BMC.
Hello.
Burjil
Yes,
Medical
please, we would
City,
like to invite you to
getting
the book
ready
signing
for-
now outside. If you can join us, please. Thank you.
The wedding of Saeed's first granddaughter was approaching, but severe gastric volvulus had overshadowed his joy. We were racing against time to bring him back to his life and home. The medical team at Burjil Medical City was prepared for Saeed's complex case. To address it, we performed a precise and minimally invasive robotic surgery for subtotal gastrectomy, removal of the surrounding lymph nodes, and accurate reconnection of the digestive system. This approach accelerated the healing process and allowed Saeed to regain all normal digestive functions. Thanks to our deep expertise and advanced surgical techniques, we were able to restore Saeed's happiness. Everyone turned to look at Saeed with joy, surprise, and amazement as they saw him standing. In that moment, their happiness was complete. BMC Burjil Medical City, getting you ready for life.
Hamdan's dream of winning again seemed unimaginable. Every second mattered in returning Hamdan to his life and passion. The medical team at Burjil Medical City was aware that the fracture near Hamdan's knee had affected his growth, causing his leg to become shorter and more curved over time. To address this, our paediatric orthopedic surgeons inserted a precise intermedullary nail into the bone to straighten and gradually lengthen the leg until it matched the other leg within just a few weeks. Followed by a customized rehabilitation program, Hamdan was able to resume most of his activities within 3 months. The moment Hamdan stepped back on the pitch, it was a victory before the victory. And now, everyone knew who the school's new top scorer would be. BMC, Burjil Medical City, getting you ready for life.
Each of us has a story filled with chapters. We were at the peak of happiness. Everything was going well. We're spending our summer vacation after a year filled with professional achievements. And most importantly, we're eagerly awaiting our firstborn.
Oh my goodness.
We didn't know that our routine visits to check the baby's health would mark the end of one chapter and the beginning of another.
Can you see the spine? Basically, the lower part of the spine is not closed. That means that the spinal cord here is completely exposed to the fluid around the baby. It is pulling the brain down, preventing.
We discovered a problem with the baby's spine and spinal cord. We were placed with many options in front of us, and we needed to pick the lesser evil out of them.
When I met Mary and Carl, they were aware of the options of either ending pregnancy or continuing pregnancy, with the consequence that this baby will be born, possibly not be able to walk for the rest of its life. We discussed the option of repairing the spina bifida inside the womb.
We had to make a swift decision. Returning home was not an option due to the risks it posed to the baby. We won't terminate.
So spina bifida is a common neural tube defect in which the spine fails to close completely. I'm just going to take the incision on the uterus, hold the baby. It's a very complex procedure and we're completely aware of the risks. It becomes an emotional responsibility to ensure that I deliver the best care. So Mary once jokingly said to me, Doctor, do you ever sleep? Because whenever I text you, you're always there on your phone. And she just texts me, shall we go and see her and her baby?
Yes, yes, of course.
Perfect, come.
Nestled within Burjil Medical City, the Kypros Nikolaides Fetal Medicine and Therapy Center proudly stands as the first of its kind in the Middle East and North Africa. Our center specializes in precise clinical diagnostics, aiming to detect and diagnose fetal anomalies as early as 14 to 16 weeks. With state-of-the-art technology, we are pioneers in performing in utero spinal cord repair surgeries, setting new benchmarks for fetal care in the region. At Burjil Medical City, our dedicated team is committed to offering expecting parents the best options and striving for the healthiest outcomes for their growing families. Because every new life deserves the finest in fetal medicine and compassionate care. BMC, Burjil Medical City, getting you ready for life.
At Burjil Cancer Institute, we offer a full spectrum of oncology services, including early detection, advanced diagnostics, radiation and surgical treatments, and palliative care. Our success rate stands shoulder to shoulder with the world's leading institutes. With cutting-edge technology and a commitment to personalised care, we've made substantial strides in enhancing patient outcomes and quality of life. Burjil Medical City is also proud to feature the ExactTrack dynamic treatment technology. This innovative system allows for real-time patient positioning and monitoring, integrating surface, thermal and X-ray tracking with sub-millimeter precision. We also offer pediatric radiation therapy and meticulous bone marrow transplant planning with the latest body irradiation techniques. Our expert team works in close collaboration with renowned regional and international centres. This technology is integral to our advanced radiotherapy programme, enabling our specialised staff to deliver unparalleled cancer care with state-of-the-art tools. Because every journey towards a cancer-free life deserves the utmost in oncology care. BMC, Burjil Medical City, getting you ready for life.
At Burjil Medical City, we lead the way in paediatric orthopedics, handling complex cases with exceptional success and minimal complications. The Paley Middle East Clinic stands at the forefront of innovation, offering groundbreaking care throughout the region. Our mission is simple: to transform young lives through cutting-edge orthopedic solutions. Whether addressing congenital issues or post-traumatic conditions, we excel in limb lengthening, deformity correction, and more. Committed to reconstruction over amputation, our expert team delivers personalised care tailored to each child's needs. We have achieved a remarkable reduction in complications for children with congenital, growth-related and post-injury conditions, enabling them to thrive and lead fulfilling lives. Because every child embarking on their journey deserves the finest expertise in paediatric orthopedic care. BMC, Burjil Medical City, getting you ready for life.
At Burjil Medical City, we are at the forefront of robotic surgery, leveraging cutting-edge technology to handle over 80% of surgical procedures with unparalleled precision. Our specialists use the state-of-the-art Da Vinci Xi surgical system, enabling complex operations with exceptional accuracy. This advanced technology provides 3D comprehensive vision and highly dexterous robotic arms, ensuring surgeries are performed with supreme precision, care, and efficiency. Patients benefit from minimized surgical intervention, leading to quicker recoveries and shorter hospital stays. Plus, Burjil Medical City offers extensive rehabilitation and physiotherapy services to support every step of your recovery journey, because every surgical journey towards a better life deserves the pinnacle of precision and care. BMC, Burjil Medical City, getting you ready for life.
Mariam worked hard to establish her company, and the idea of giving up never crossed her mind. Every moment was crucial in bringing Mariam back to her life and her work. Our medical team at Burjil Medical City knew that Mariam's case was sensitive, especially since the type of cancer she had was rare and needed to be addressed as quickly as possible. For this, our specialists in gynecologic oncology relied on minimally invasive robotic surgery to remove the cancerous tumor, ensuring high precision, reduced pain, and rapid recovery. After comprehensive analyses and examinations, we scheduled Mariam for advanced radiation therapy sessions to eliminate any remaining cancer cells. The moment Mariam re-entered the company premises is one that no one will ever forget. BMC, Burjil Medical City, getting you ready for life.
The wedding of Saeed's first granddaughter was approaching, but severe gastric volvulus had overshadowed his joy. We were racing against time to bring him back to his life and home. The medical team at Burjil Medical City was prepared for Saeed's complex case. To address it, we performed a precise and minimally invasive robotic surgery for subtotal gastrectomy, removal of the surrounding lymph nodes, and accurate reconnection of the digestive system. This approach accelerated the healing process and allowed Saeed to regain all normal digestive function.
Bismillah ar-Rahman ar-Rahim. If you could please take your seat. We're already half an hour late and would like to move forward with our second session. And we'll start with the talk about palliative care advocacy, award free from health-related suffering, by Dr. Catherine Pittis, who is the Senior Advocacy and Partnership Director, International Association for Hospice and Palliative Care from the US. She joined the IAHBC in 2014, and she is now the Senior Advocacy and Partnership Director, working with a global organization to promote palliative care and ensure access to essential medicines. She mentors members, develops advocacy courses, and speaks at the international conferences. She holds a PhD from Columbia University and degrees in health law and policy and arts laws. She is also an accomplished author and enjoys spending time with her family, reading and traveling between Taos, New Mexico, and Spain. The session is recorded, so if you can please play the video. And
first of all, I'd like to thank Neil and the organizers for including me in this first Emirates conference on palliative care. It's a great honor to take my place among this star lineup. I'll try to do justice to the invitation and explain in a very short time what advocacy for a world free from health-related suffering actually consists in. For more information, because I'm just going to give you a very rapid bird's eye view, please visit our website and join the IHPC so that you can advocate with our delegations at multilateral meetings. So I've ticked the second two bullet points because it's in these two institutional affiliations that authorize us to advocate at the United Nations at that system level. The IHPC is a global membership organization. We've been legally registered in the US since 2002. We're in official relations with the World Health Organization, and we're in consultative status with the UN Economic and Social Council. We have a global board of directors, and we have 4 pillars of work: education, advocacy, research, and information dissemination. Our vision is a world free from health-related suffering, and our mission is to serve as a global platform to inspire, inform, and empower individuals, governments, and organizations to increase access to and optimize the practice of palliative care. And that's a consensus vision and mission statement that we came to through our strategic planning with the board. So IHPC advocacy and public health advocacy in general is done through accredited civil society organizations, not by individuals acting on their own. And civil society advocacy organizations such as the International Association for Hospice and Palliative Care have a recognized legal right to participate in UN organizations. And this is straight from the UN website, that it says we play a vital role as partners in the UN in implementing the development goals and assisting people at the local level in countries across the globe. So it recognizes our value. And I also think of it, and you're all medical people, so you'll understand this, that advocacy is really like being connective tissue or synapses between impacted populations, and that's your patients essentially, and policymakers. And by impacted populations, they're impacted by disease, by poverty, by lack of access to palliative care, lack of access to medicines, proper food, trauma, war, climate change, you name it. We advocate by sending delegations who represent those patients and impacted populations and caregivers to multilateral meetings. Those are international meetings in the UN system. And they're delegates who are our members who have some expertise in particular subjects and who's volunteered to go. And anyone who's a member of IHPC can apply to join a delegation to one of these meetings. Unfortunately, we don't have very much money. We're very limited in our funding, so all our delegations have been self-funded. But they're all full. We have full delegations at all the meetings, so there's tremendous desire to participate and do this. And I mentor those delegations through the meetings. You're not going to go in there cold, don't worry. The other thing is that advocacy is distinct from lobbying. It's quite a different process. So a more lay description in common language rather than the more technical language I've been giving you is that in terms of the principles of advocacy, it's really a form of faithfulness, even doggedness, never giving up. Advocates show up with evidence and testimony in any place where we might be able to build influence and relationships with decision makers. We take the long view. We don't expect short-term results. We're often out of our comfort zones because that's where the growth is, as the cliche says. And just like palliative care practice, advocacy is interdisciplinary and multidisciplinary. We build trust within and outside our teams with our conversation partners in government. And I love thinking of it as love with its sleeves rolled up, really, or love in action, love of our communities, our patients, our families, and one another. So that's the informal definition. But more formally speaking, that love in action gives voice to suffering. And the etymology of advocacy and its meaning for palliative care, it comes from the Latin ad and voc, which means to give voice to. And what do we give voice to in advocacy? To health-related suffering. And so as practitioners, you as advocates give voice to your patients and to their families' suffering when you advocate. But first you have to educate yourself about your audience. Who are you speaking to? About the situation in your country, the statistics in terms of health-related suffering. And then you proclaim. That's what advocacy is, proclaiming. And you invite policymakers into conversation, as the photo shows me doing. I'm proclaiming at the World Health Assembly in Geneva. I'm giving a statement. And then you invite your policymakers and other influencers into conversation on the topic. Advocacy is an ongoing process of building relationships. It's not a one-off. That's why I said we take the long view. And this conference itself can be a work of advocacy as you educate yourself with your expert speakers, and then you proclaim to your policymakers that you have learned this and that this is what you would like to institutionalize in your country, your health system, your hospital, whatever your setting is. So you go forth and enter into relationships with new conversation partners who can take steps to integrate palliative care into those institutions or health systems so that it's not a luxury for the fortunate few who can afford it or who have insurance. We advocate for public health palliative care as a public good. And the World Health Organization actually calls palliative care a global public good. So we need to be clear about how suffering, health-related suffering, fits into this global public good. It's not suffering per se in the Buddhist sense of the first noble truth that all life is suffering. That's distinct, but it's IHPC's vision is a world free from health-related suffering, which is based on the consensus definition that you can find on our website, created by global practitioners, some of whom are at this conference, through a Delphi process, and it's based on the original, or revised, I would say, 2002 WHO definition, which has quite a few components. And it has those, you can read those elements and components on our website. But the definition of palliative care is active, holistic care of individuals across all ages, so from neonates to older people, with serious health-related suffering due to severe illness, and especially those near the end of life. So health-related suffering, and this is the definition, is associated with illness or injury of any kind, and it's serious when it cannot be relieved without professional intervention, and it compromises physical, social, spiritual, or emotional functioning. And that definition is our North Star of advocacy. So now we've described the what we advocate for. Let's look at the where and the how of advocacy. So we advocate at local, national, regional, international. Those are the multilateral spaces of power. We do it, as I said, through relationship building, and that this entails understanding the institutions, the policy and the politics of the place where we're advocating, and connecting impacted populations, as I've described that already, with decision makers. And we have to understand the goals and influence local, national, regional, and international policy. In other words, we read the agendas, we understand the goals of the policymakers, and we try to align our message with the goals. So that's a lot of compressed information, which is why you get a copy of the slides later. My presentation is largely focused on international policy, since the multilateral system authorizes and legitimizes regional, national, and local policy. So we are at that level, and we try to legitimize the policy making at all those other levels. What is the multilateral system? It's a system with many sides, as the word suggests, and it's part of the UN government structure, which is member state driven. It's always driven by member states, 194 of them, each of which has one vote, at least technically, in the system. Civil society organizations, as I've said, are part of that. We're recognized part of it, but we can't vote. We can just consult. There are many functional agencies and organizations with secretariats, and these are the main ones we advocate in at the World Health Organization, the Commission on Narcotic Drugs, and the Human Rights Council. Because these are the organizations that create and oversee the evolving global normative framework, which now includes palliative care. So this is the sphere of influence where the IHPC works, because we're institutionally affiliated with the UN, as I said in the beginning. And at the UN, as a result of more than a decade of advocacy at this level, representatives of your governments, because this is an international conference, which also make the laws and policies of your countries, have created what's called a normative framework to support palliative care and access to palliative care medicines. A normative framework is just a term of art, which means all the different laws and policies which they have committed to. And as civil society organizations advocating at the UN, we participate in the meetings, but as I said, we can't vote. And what we do is we bring back the accomplishments that we've had, and I'll go to those in a minute, to the national and regional, like this conference is a regional sphere of influence, so that then you can use them in turn in your spheres of influence. So the global normative framework is the human rights laws and covenants. These are evolving Human Rights Council and Office of High Commissioner documents. The covenants were usually agreed to in the mid-1960s, 70s, but there are documents which update them. And one of those was what's called General Comment 14, of the Office of on the Covenant of Economic, Social, and Cultural Rights, which includes palliative care as part of the right to health. So that's what I mean by evolving. Then there's global and public health law, which is the World Health Organization is the Secretariat. Drug policy, which is overseen by the Commission on Narcotic Drugs. That's where the medicines are overseen that we use. The rights of older persons, the open-ended working group on aging appointed by the General Assembly, and the participatory rights of civil society are overseen by the Economic and Social Council, or ECOSOC. So this is the global normative framework that authorizes and legitimates the national laws that in turn authorize and legitimate your bedside practice. And it's always aspirational. It's important to remember that. It's approved by representatives of all the world's governments, but it has to be implemented at the ground level as a result of advocacy by practitioners such as yourself. It's not self-implementing or self-executing. It doesn't just happen. Your advocacy at the national level and the regional level is what makes happen what we do at the international level. The normative framework consists, as I said, of human rights covenants that set down standards that are agreed on at the Human Rights Council and the Office of the High Commissioner for Human Rights. And our advocacy has now included older persons' rights to palliative care and resolutions at the Human Rights Council, declarations of the Commission on Narcotic Drugs, and it's part of the discourse now at the General Assembly in terms of older persons' rights too. So these are some selective global advocacy accomplishments that we have accomplished with our partners. It's always collaborative, and other global associations over the years, starting, of course, with, see how recent this is, just 10 years. The 2014 World Health Assembly resolution, this is the 10th anniversary. 2016 was a really important year for availability of controlled medicines in terms of our advocacy, but that again has to be implemented at the local and regional level. 2018, the Astana Declaration on Primary Health Care, which originally did not include palliative care because of our advocacy, it now does, and palliative care is now officially part of primary health care. 2019 to 2023, there are several declarations on universal health coverage, which now include palliative care. 2021, there was a Human Rights Council resolution on older persons, which now includes palliative care. And then in 2023, there was the Commission on Narcotic Drugs joint call to action on essential medicines. And also last year, the draft pandemic treaty on preparedness and response, because of our advocacy, now includes palliative care. So there has to be uptake through the national and regional organizations and associations of palliative care in order to enact those accomplishments so that it reaches the bedside. And these are the levels of governance for PC advocacy, palliative care advocacy, These levels are all interactive and dynamic to some extent, and I wish I were clever enough to design it in an interactive way or use AI tools to demonstrate that, but I'm not. There are some barriers, though, for instance, at the national level and the regional associations on the right. So these are all the regional and national associations and some global. The globals are up here. These are the regionals, and these are just some selected. There are too many to include. National associations. The national associations cannot advocate at this level. Only we can do that. The regional associations cannot advocate at this level either. So everyone sort of has to stay in their lane, but they all have to be accredited with the national government, the regional level, or the international level. And if they're properly registered to advocate at the corresponding national or regional level, Then they must enter into some sort of accreditation so they can influence the member states and governance at that level. So that's another important piece, is to understand which level you're accredited to and where you can advocate. And if you want to advocate internationally, that's why I said you need to join IHPC to advocate with us. But there's no one-size-all formula for advocacy. It's an institutional process, and it requires attention to the various parts of each institution. So I can't just say this is what you should do for your institution. You have to find that out and do the research on that. So there are phases in context of advocacy development. There's the early, the pioneer, fire in the belly leadership right at the beginning, which doesn't require an institution or an association. And then there's the sort of middle phase, or the settler phase, as it's called in business advocacy, business theory, where you gather like-minded professionals, you study, you join other associations, and then you consult. And then later, there's what's called in business theory, again, the town planner phase, where you consolidate what's gone before. You recruit board members, you create and register institutions, you develop strategic plans, and you identify advocacy focal points. Most EMRO countries are still in the developing or capacity building stages, according to the 2021 Global Atlas of Palliative Care, and most still have insufficient availability of controlled medicines. Some don't, some have good availability, but the ones that don't means that you need to generate and gear your advocacy to your context. So where there's no association, build one. Include in your advocacy your strategic plans, and IHPC consults with our members institutionally and individual to help you do that. These phases of influence can be described in terms of, again, a dynamic process, so you amplify your spheres of influence. We accomplish the goals we discussed earlier, those accomplishments, by amplifying our spheres of influence at the global level through partnerships with other global, regional, and national institutions that were already established, because obviously we couldn't build other institutions. So we amplified our spheres of influence. Many of you would probably describe your professional circles of influences as limited to your patients and their families and your colleagues within the institution. That would be here. And then advocacy expands that to your institutions, so that you're then advocating in your institutions, beginning with your professional associations, even maybe persuading your palliative care association, which is heretofore focused on clinical education, to consider doing advocacy, which can be very influential in some countries. Then you widen your sphere of influence to your city, your district, your province, and then you get the picture to your country, and then to the multilateral sphere. You do that by building up your influence with other organizations and influences, including the media. Some advocates have been very successful with the media to create public awareness about the need for palliative care. So when you do that, you're creating what's called a virtuous circle, whereby each circle increases the benefit to the next circle. And I'm going to explain the structure of the multilateral level, which is where IHPC has influence, but only because the circles build in a dramatic and, I have explained that already, in a dramatic and synergistic, dynamic, not dramatic, way. These are our main advocacy challenges: the opioid phobia, the North American opioid crisis, which has gained so much publicity, has really retarded a lot of our efforts to improve availability of controlled medicines, because so many countries that really want to improve availability are afraid they'll have the same public health crisis. So we're really working on that with the UN Office of Drugs and Crime, and a recent meeting we had on diversion of controlled medicines. Global pharmaceutical marketing is a big challenge because they only want to market the profitable medicines, not morphine, which is not profitable. But there are strategies that can counteract that. Many misunderstandings about palliative care, which I'm sure you're all familiar with, the main ones being it's only for cancer, only for the end of life. The policy focus in global health on saving lives rather than taking care of the people whose lives cannot be saved has been a real problem for us in global health. And most recently, the very well-funded global euthanasia movement, which also has a connection with lack of funding for advocacy. Because as more investment goes into assisted dying and euthanasia in some countries, there's a corresponding lack of funding, and there's now some evidence for this in Canada and Australia, that there's a lack of funding for palliative care, disinvestment in palliative care, but there's a real lack of funding for advocacy that we have been dealing with. So some takeaways: determine your context and your phase of institutional development, so then you can decide which level to advocate at. Identify and expand your spheres of influence slowly and systematically. Assess population needs and engage in strategic planning. And there's lots of really good data coming out on population needs and health-related suffering. Engage in strategic planning with your association. And of course, join IHPC because we can help you with a lot of that. We've got courses for our members on pain and symptom management as well as on advocacy. So thank you, thank you.
Thank you so much. And actually, Dr. Catherine, she'll be with us during the discussion. She'll be joining us virtually. Moving now to another topic, and very important topic, which is palliative care in the midst of humanitarian disaster. A colleague reports from Gaza, Professor Khamis, who's a neurorehabilitation pain medicine consultant, did his MD from Far Eastern University, Manila in 1998, and completed his master in clinical training in medical rehabilitation at Southampton University, a fellowship in neurological rehabilitation at Tel Aviv University, and diploma in palliative care from the German Jordanian University. And he headed the medical rehabilitation team at Al Wafa Medical Rehabilitation Hospital in Gaza until 2011. Since 2008, Dr. Al-Aisi has been teaching evidence-based medicine and neurorehabilitation at the Islamic University of Gaza, where he chairs the ABM unit. The session is recorded, but he's also with us online. He will be joining us in the panel discussion. Can you please the video?
Thank you so much for inviting me in to join your elegant conference. I'm truly honored. Thank you, Dr. Neil. Thank you, Michelle, for all your efforts to coordinate this. The title of my talk will be Palliative Care and Pain Management, a summary of 13 years journey of service development and implementation strategy in the Gaza Strip. My name is Dr. Kemi Selassie. Just before I start, my presentation covers the period between 2010 and 2023, just prior to the war. Just for your knowledge before I start, Gaza Strip is a tiny piece of land that is 42 kilometers long and around 6 to 10 kilometers wide. It has a population of more than 2.3 million and an area of 365 square kilometers, with unemployment almost more than 55% prior to the war, and food insecurity is 2/3 of the people. Almost 2/3 of the population of Gaza Strip are refugees. This tiny enclave has been under strict siege from land, sea, and air since 2007. As you all know, palliative care is a holistic medical approach to improve the quality of life, not only of the patient, but also of his family and caregivers. And palliative care is not limited to the end-of-life care only, but also to patients who are suffering from chronic illnesses as well. Palliative care and pain management should be a basic human right for everyone. And this picture shows the most recent model of palliative care that starts palliative care from the first time of diagnosis until death, and after that in the bereavement period. In armed conflicts, palliative care is becoming more crucial component of healthcare, especially when providing relief and support for individuals with injuries and life-limiting illnesses. And the necessity of palliative care in Gaza Strip is more evident due to high prevalence of life-limiting diseases such as cancer, chronic illnesses, which are all exacerbated by the ongoing conflicts and repeated wars and the long siege imposed on Gaza. Just for your knowledge, in Gaza Strip, we have more than 11,000 individuals with cancer, and we have more than 350,000 individuals with chronic illnesses, including diabetes mellitus, hypertension, and heart disease. Gaza Strip is a unique place, and that's why providing palliative care is more crucial in the Gaza Strip, because most Gazan people are living under unique mosaic of poverty, siege, repeated wars, devastating health conditions, beside harsh psychological, social, financial, and political conditions. And all of these special conditions have its negative impacts on health. So under such volatile circumstances, the need to protect an already vulnerable population and securing and providing necessary treatment is becoming more challenging. And the same is true in providing palliative care and pain management. These are some of the pictures of the repeated wars on Gaza with its mental, political, and medical impacts on the people. And the picture in the middle, shows the long lane of people departing their homes in seeking more secure areas in the recent war. There are many repercussions influencing of the siege on Gaza. Some of them, the siege was imposed since 2006 and has affected every aspect of our life, and including the movement of the people in and out. So patients and their relatives must apply for a permit to exit Gaza Strip to seek better treatment abroad. And to have this permit, you need to apply for a long period, and that could take between 6 months and 1 year. And many of the patients who are applying for this permit get rejected, which means that the patient could die before even receiving that permit for treatment. What global research say about the importance of palliative care and the need for palliative care? It says that most cancer patients are diagnosed at late stage, especially in poor-setting countries like ours. Poor communication skills negatively affect patient outcome. Inappropriate patient control lead to unnecessary suffering, and most patients exhibit poor quality of life after diagnosis and near death. Unfortunately, most patients suffer from unresolved symptoms towards the end of life. And this list shows the most common symptoms experienced by most patients who are having cancers or chronic illnesses. And they include problem with breathing, nausea, vomiting, sleeplessness, confusion, depression, loss of appetite, and constipation. In Gaza Strip, a research conducted by Mr. Hamouda et al. Showed that almost 96% of all patients' needs were not met in the healthcare system in Gaza Strip. Also, it shows that the level of unmet needs and the level of distress is high, especially when speaking about physical symptoms, including fatigue, anxiety, and pain. Almost more than 78% of our patients have high level of distress, and almost 90% of them showed signs of depression and anxiety. We have done some humble initiatives and some activities to promote better pain control and palliative care for our people. The first initiative we started was in 2010. It was with a small grant from International Association for the Study of Pain, and this initiative aimed to promote evidence-based pain assessment and holistic management. And in this initiative, we cover 120 members of our medical staff at Al Wafa Hospital under the flagship of Pain is the Fifth Vital Sign. And we managed to teach our staff the art and science of pain management and how to assist her properly and to act quickly. This is some of the photos to cover that initiative. The second one was to promote palliative care and comprehensive pain management among doctors and healthcare professionals in other hospitals. And the main player was Ali Arab Hospital. So in this hospital, from 2011 until 2015, we conducted a series of workshops. In fact, there were around 6 of them, and we targeted around 300 healthcare professionals. Each workshop covered 2 to 3 days, and it was conducted with the help of Dr. Bird from Australia and myself. And with this, we showed positive impact on the professional understanding of pain concepts and holistic care of patients who are suffering from chronic illnesses and cancer. The third one was to have a palliative care and pain management model for integrated in the society. And to do this, we started in 2015 with the help of our dear friend, Dr. Liz Grant and Dr. Maura Link and her palliative care team from Edinburgh University to draft an evidence-based curriculum for palliative care and pain management for undergraduate medical students. And through this, we conducted regular courses for our students, regular workshops for medical professionals. We also drafted an evidence-based palliative care and pain management diploma course for postgraduate doctor. We also organized meetings with different stakeholders, including WHO, including local NGOs, including different hospitals. These are some of the pictures of our work so far from 2015 until 2023. Some of our students, some of our collaborators, some of our online courses during COVID-19. After 7 years of starting this, we have managed to teach almost 300 students on the art and science of pain management and palliative care. We have conducted 6 workshops. Many meetings were held in the Ministry of Health in cooperation with WHO and UNRWA, different universities and different NGOs. We also link local doctors with international doctors. We form a steering committee to carry out and promote and oversee the implementation of palliative care and pain management in the gastro. The fourth initiative was to start the first palliative care team at Rantisi Pediatric Hospital, and that started in January 2019. We did a series of lectures and training courses for selected staff members, and these are some of the photos that we have for that team at Rantisi Hospital. The fifth initiative was to encourage engagement in palliative care and pain research. And so far, over the last 13 years, we have been part of 15 research papers and documents tackling pain and palliative care. And these are some of the list of these papers. Our sixth activity was organizing the first international conference on Palestine under the title Pain Management and Palliative Care. And this conference focused on really making an evidence-based foundation for pain management and palliative care. And we invited almost 500 doctors locally, and we invited delegations from the United States, Norway, Britain, Japan, and Uganda. And the conference ran over 2 days. And on the second day, we had 2 workshops completely delegated for pain management and spirituality. And this is some of the photos of since the preparation and workshops for this conference and the conference itself. Here we see Dr. Moira and some internationals with us. More photos of the conference. And more photos. The conference was a huge gathering with more 500 doctors and around 20 international experts in the field. Also, we conducted a training day for 22 doctors and other health professionals from European Gaza Hospital, and to teach them the art and science of palliative care and management, pain management. Latest activities conducted in 2023, it was conducting the 7th palliative care and pain management module for our students. And over 5 days, we did that for our students in the Islamic University and Azhar University. And we taught those undergraduate students the art and science of pain management and palliative care, with a goal that those students will be a future leader in this art and science. And these are some of the photos of this workshop. Also, the main activity that we have done so far in the year 2022 and year 2023 was conducting the first ever pain and palliative care diploma to be conducted in Gaza Strip. We managed to develop an evidence-based palliative care and pain management diploma for postgraduate. And we started the implementation of this. We selected 24 medical professionals from different hospitals, including doctors, nurses, psychologists, physiotherapists, and pharmacists. And the first batch finished their course in October of 2023, just before the war started. And this is the hospital, the Turkish-Palestinian Friendship Hospital, where the diploma course was conducted and implemented, and the training was carried out. These are some of the photos of the palliative care diploma program, teaching from the first day of inauguration with the presence of WHO and internationals, to the conductance of education and training, more workshops and more training, informal teaching, more teaching and more lectures. And this is our team at the Turkish-Palestinian Friendship Hospital, which was, by the way, an elegant team made of almost 13 professionals who cared for cancer patients and patients with chronic illnesses. But as I've mentioned, that was just before the war, because after the war, everything finished. The way forward, what's next? After the current war is over, and we hope it will end soon, we hope to expand our educational content of health-related curriculum to other Palestinian universities and hospitals. We also hope to start a community-based palliative care services. We hope to join as active members in the relevant international palliative care initiatives worldwide. In conclusion, as of October 2023, before the war, despite the protracted siege for 17 years, despite devastating wars and severely limited resources, we succeeded to develop and start a series of unique initiatives to promote a comprehensive pain and palliative care educational training courses that has benefited thousands of medical students, thousands of doctors, and thousands of cancer patients and sufferers of chronic pain illnesses in the besieged Gaza Strip. Together, we build life. Together, we add life to the days of our patients. Thank you so much. And let me say that despite this siege, we always look for a brighter tomorrow and a peaceful future. Thank you so much.
Dr. Khamis, this was very inspiring talk and definitely very insightful in how you continue providing care for your patient despite all the challenges. I'm sure we will be having more questions and you'll be with us in a few minutes. Now we'll move to Dr. Joy Ross, who will be talking about lessons learned from 57 years of St. Christopher's Hospice and Community. Dr. Ross trained at Guy's and St. Thomas Medical School. She completed her PhD at Imperial College London, studying the pharmacogenetics of response to opioids. She has worked at the Palliative Care Consultant, St. Joseph Hospice London, and then at the Royal Marsden and the Royal Brompton Palliative Care Service. She's currently working at the St. Christopher Hospice with a special interest in developing palliative care services for the frail elderly and those with non-malignant diseases, including heart failure, which is very, very important disease sites that we tend to forget and focus only in cancer. Welcome, Dr. Ross, and thank you for joining us.
Thank you to Burgill Holdings and to Neil and the team for inviting me to speak here today. And I bring greetings from the team at St. Christopher's and from Dr. Heather Richardson. She's currently has welcomed a number of people from different countries to St. Christopher's to learn together as part of our Beacons project, which Burgill Holdings are also going to be part of, to think about how we bring together learning, professional learning and education, and how we contextualise that to really put into practice these principles in different situations. So Neil's given me a rather ambitious title, and therefore I'm going to sort of take this in a few different avenues, and I'm really happy to talk further about any of the areas during the breaks and over the next 2 days. So there's something really important about looking back. And as I think about the insights and what we've learned at St. Christopher's over the last 50 plus years, one of the things I want to just show you is a few different insights from our oral history project. It's really important that we notice and we show gratitude for and we celebrate the things that go well as we learn and we develop. And it's also really important that we notice and give space to reflect on and learn from mistakes that will happen along the way if we are really true innovators who are taking work forward. And secondly, we need to look forward. We've got a changing world around us and we've got to adapt. We've got to look again at where the changing need is. And we've got to really learn how to build on the principles of the past to really continue to innovate as we move forward. And lastly, it's really important to look around us, and that's part of what we're doing here today, to see what others are doing in other areas, to partner with others, and to continue to learn and encourage each other together so that we can really share and apply learning across the different settings we work in. And at St. Christopher's, we work at a local level across 5 big boroughs in London. We work to try and influence at a national level, particularly with other hospices and with others who are working in palliative care. And increasingly, we are really proud of the opportunities we have to work at a global level. So many of you will know of Cicely Saunders and her work and her legacy, and a lot has been done to write about her. But part of our oral history project was to really seek. They interviewed over 70 people who had lived and worked, been part of those early years at St. Christopher's and since then, to capture some of the stories of what had really gone on and to look in a bit more detail about what we'd learned. And I've put here a quote relating to Robert Twycross, who many of you will know and have heard of, and he was a clinical research fellow at St. Christopher's, and he did a lot of the seminal work around use of opioids, morphine, diamorphine, methadone in pain control. And one of our previous medical directors wrote this about him. What was most striking was Robert's presence and presentation. He was a very scientific man, a man of rigour when it came to medicine and the analysis of problems. At the same time, he knew that there was no use unless he was seeing patients as part of society whose comfort was not just a matter of the pharmacology, but also of their psychology, and yes, even their spirituality. A holism that I hadn't encountered in healthcare up to that point. And you've already heard today, there's a lot about the science of medicine, and palliative care has to be robust in the way that it researches and it evidences what it does. But there's also a real art to it in how we connect and focus on the person in front of us, not just on the illness that they're presenting with. I've also put here a quote from Rosemary. She encounters her experience as a 16-year-old volunteer working on Alex ward in those first couple of years. And she tells how the matron at that time sent her to give a bed bath to a patient. She didn't know how to do that. It was a new experience for her. She hadn't been trained in that. But she said that the ward nurse really knew what she was doing as she found out that the patient was actually an ex-nurse who taught her and talked her through what needed to happen, different ways of learning in different settings on the job. And Anne Nash, one of our current nurse consultants, describes the nursing role as being respected and valued. Her learning from senior nurses around her and observing their autonomy and the place that they took in the multidisciplinary team. And one of the things we're really proud of at St Christopher's is the way that our nursing colleagues take a real lead and a real role in both assessing and delivering care. And they work as part of that team alongside us. And some of our professional learning programs have looked to really build and raise up that nursing model of care and to respect it and to really celebrate it. And my last quote here is from Dr. Mary Baines, and this interview with her took place actually just a few months before she died at the age of 87 at St Christopher's Hospice. And she worked with Cicely, and she's reflecting on the start of home care, moving out from beyond the hospice walls into the community. And she said, a woman in her 40s with breast cancer and a lot of pain came to St Christopher's for pain control. We controlled the pain using, a moderate dose of diamorphine. But she amazed Cicely by saying, I'm enormously grateful to St Christopher's for all they've done, and I like it here, but would actually rather be at home. And she was the start of actually then Mary Baines going on to develop what has now become actually the bedrock of our services of caring for patients in the community setting. So there's some key reflections from the past which are captured from this Oral Histories project, and which I would argue we've got to hold and embrace for the future. We have to be prepared to be radical, and we have to together support ongoing innovation to develop services and care. We have got to adapt and change with the times. We've heard an awful lot today about how we as professionals, as we take forward palliative care, have to be able to respond to and hold the experience of suffering in those around us. And as we do that, we have to remain true to the founding values of the pioneers who've gone before us. And for me, there's something really important in how we invest in a strong multidisciplinary team approach. As a doctor who leads and takes an active role in leading in the hospice, I more and more see the importance of how I work with and work alongside the multidisciplinary team around me. And we have to be committed to growing a talented workforce, and we've had to morph and change our workforce at the moment at St Christopher's to meet the growing need around us. And part of today is being generous with our learning with each other. And we have a centre now for professional learning, which is taking that forward at pace. And for me, how we build and nurture relationships, both internally with the colleagues we're working with, but also externally with other colleagues across the system, will be key if we're going to succeed. So I've put here some of our strategic ambitions. We're looking at St Christopher's to really move forward to tackle inequalities in access to palliative care services. And even in the UK, there is marked inequality for those from some ethnic groups, from those with some protected characteristics, in accessing the services that we want them to have. We want to fulfil a national and a global leadership role. We want to be able to create a sustainable business model, and I'll come back to that as I move forward. And we want to be able to together equip the future workforce. We've got some real key ethical issues that are coming up, and Catherine Peters alluded to one of them around the whole topic of assisted dying. So I want to move on now to say that it's really important that we use both data and stories effectively. And you've heard lots of stories already today that really help you to understand more of what the value of palliative care can bring. On the left-hand side of the screen, I've shown you data from the meeting this week, the day before I came to the conference here. It shows you that at the top that our community caseload has gone up from what was around 1,300 patients to now 1,700, 1,800 patients over that year. And our clinical team review this data once a week. It shows where we're increasing our reach, but it also brings with it challenges for how the team will meet that growing need. The graph at the bottom shows patients who've died, but also patients who we're now choosing to discharge. We can't manage a growing workload. We've got to change the model of care, the way that we meet initial need, and maybe discharge patients to come back to us at a later time when we can give more input to them. And on the right-hand side of the graph, you'll see some of the Hospice UK data, showing that now in the UK, 60% of palliative care from hospices is going to patients with cancer, 40% now with non-cancer. And at St Christopher's, we've moved that forward even further, with just over half of our patients now have predominantly non-malignant diagnoses. And then if you look below at the age distribution of who we're reaching, actually the biggest challenge for the UK at the moment is the increase in looking after ageing older adults with frailty. And in St Christopher's, it's even more marked than that Hospice UK data, where 40% of our patients we're looking after now are in the 85+ year age group. And at the other end of the scale, we've actually got increasing numbers. 15% of our population at St Christopher's are in that 25 to 44-year-old age group. And at both ends of the spectrum, that raises different challenges for us in the care and the services that we need to be providing. So what's some of the impact of increasing non-cancer care? Well, first of all, who should we see? We've had to develop and change our referral pathways from the traditional cancer model of care. We've had to think about how we can change the model. With frailty particularly, we're looking at a short interval of palliative care that could do an assessment, put in some rehabilitative palliative care, actually signpost the patient and the carers to other services in the community that they could link with. And also, having built that relationship, be ready at a later stage to come back and provide care in the last days or weeks of life. In the UK, much of care is being pushed out of hospital into the community. We've had to get to grips with virtual wards. What's the role of palliative care in a hospital at home and a virtual ward model of care? This has meant we've had to do different levels of education and training for our staff who may not be as familiar as working with some of those other diagnoses. The challenge of dementia is increasing. Both patients living with dementia alongside other illnesses but also now increasing patients dying from dementia right at end of life. And as that multimorbidity and long-term conditions are increasing with our scientific advances and the healthcare that's available, we run into other challenges with multiple comorbidities and multiple medications and getting away from a siloed way of practicing care. I've been learning lots about joint working with other specialists. I'm really encouraged here to meet one of the geriatricians earlier who's come as part of this conference. I work very closely with them now, as I do with the cardiologists, because it's not about one or the other, but it's about together sharing our learning and bringing different things to the table to improve the palliative care for the patient in front of us. And it's also really important that we contribute to the knowledge base and share our learning. And I'm going to move on now to talk a little bit about formal evaluation of some of those outcomes. So one of the things that we've been using for a while now at St Christopher's is a validated outcome measure called IPAWS. It's a palliative care outcome score that looks both at physical symptoms but also at the more psychosocial aspects of care, anxiety, family anxiety, whether patients' spiritual care have a sense of peace, what are their information needs, what are the practical problems. And you can see on the graph on the left that if you look at what's for now is 4 years of data for us, that's looking at 11,500 patients over 14,500 episodes of care, you can see the prevalence of those different symptoms from that scoring system when they come into our services. And we use this scoring system to help our clinicians focus on what's most important, what's most troubling for the patient at a different time. And we're using this data to also think about, as we move forward, how we develop our services. So you'll notice that the most prominent things that are bothering the patient is weakness and lack of energy and poor mobility. Yes, pain is there, but it's not the most prominent thing that's troubling them. So alongside that, development of our rehabilitative palliative care and input from our AHPs has been really key. But what's really important is, do we make a difference? And one of the things that you can do with the IPAWS scores is you can then take further scores later on as the situation develops or at the end of a patient episode of care. And this graph shows on the right the improvement in a symptom in green for those patients who are getting better or improving with the palliative care input. Of course, on the left to the red, there are a number of other patients where those symptoms or those needs are actually getting worse. But we can use this to demonstrate effectiveness. We can use it to feed back and encourage our staff. We use it at patient level and at population level, and we use it to influence our stakeholders, our commissioners and our trustees, to evidence-base the impact of the work that we're doing. And this work has been done in conjunction with Prof. Murta and her colleague Assam, who does a lot of the analysis at the University of Hull. And they've been instrumental in helping us to start to gather data and to put these outcome measures into routine clinical practice. I'm going to go through that one. So I'm going to move on now to another area. So in the news recently and over the last few weeks, the impact for us in palliative care in the UK of NHS funding has been really real. A number of hospices have had to reduce some of their services because of lack of funding. We're reliant in the UK mainly on charitable funding for at least 60% of our costs, and the other 40% comes from the National Health Service. Patients don't pay for care themselves, and indeed, if you look at insurance companies, won't fund people for palliative care specifically. But that's meant that in the UK, a fifth of UK hospices have had to start to cut services. We haven't at St Christopher's, but we know that this is a fight that's going to go on in the future. So as part of that, coming back to Catherine's talk earlier, we've had to go and be present and lobby. This is some of our team at Parliament last week. They went and set up a pop-up hospice charity shop, which then a number of MPs, over 100 MPs, came through to talk about the reality of the challenges in hospice funding. The cost for running St Christopher's service was 28.5 million over a year. Actually, 620,000 people came and bought things in our shops. The funding from our shops is one of the key things that really helps us. But in addition, 14,500 supporters donated money to us. We are truly of and for the community. We can't do the work that we do without community engagement and community support. And that also helps us to really develop and take forward some of the death literacy work that we're doing, helping the local community to understand more of what we do, understand more of the value of what we do, and begin to have a language themselves to be able to talk openly about death, dying, loss, and grief, which affects every one of us. One of the other things, as they were talking about funding and MPs were coming through the shop, was many of them started to ask questions about assisted dying. If you've been looking at the news, you will know that there's a bill going through Parliament in the UK at the moment. And on the left-hand side is the Sky News that was broadcast just last week from us at St Christopher's, looking at really pushing forward the fact that end-of-life care and palliative care and the funding to support it must be fixed before this legislation comes through. There's a young patient with learning disabilities, and he had cancer and was cared for 3 years for St Christopher's, and he tells his story through one of our nurses of the impact of good palliative care that enabled him to be cared for at home. But alongside that, Lord Monks talks about the way that his son, a young son, died from motor neuron disease, and some of the suffering that they as a family endured as they watched that. And a lot of that is driving the argument at the moment around assisted dying. And then there's celebrities like Esther Ranson, who has progressive lung cancer. And these stories are really important. But I would also challenge us about how do we hear the voices of our communities, but also make way for those with no voice to be seen and heard and access our services. And one of the things our community action team has been doing over the last year is they've been out and they've been doing interviews and talking with and focus groups with over 50 members of our community to start to explore their views that are not really heard in the public arena about what they understand and what they know, both about palliative care and their views around assisted dying. And these voices from the community are starting to help us to shape and think about the way forward. So I'm going to leave you there with a picture of St Christopher's. You're welcome to come and visit us at any time. And our professional learning centre, which is now starting to connect with people, not just locally, not just supporting our staff with their learning, but also with many of you globally. And there's lots of faces in the audience here who I know have linked in with that. And remind you that you matter because you are you, and you matter to the end of your life. And as we seek together to really make sure that palliative care is accessible for every person at any stage, I want you to remind yourself that you're also important, and how we care for each other and how we continue to hold the suffering that we encounter as we walk alongside people is also really important. Thank you.
Thank you so much, Dr. Ross. And actually, this is very insightful. Certainly, we do share many common themes when it comes to funding, when it comes awareness, and also different things I'm sure we'll discuss Can we have our other speakers, Dr. Catherine and Professor Khamis? Are they online? So we'll start with any questions directed to Dr. Ross here. Any questions from the audience? So, Dr. Ross, you mentioned something very important, which is the lack of funding for hospice care, which is unfortunately a very common theme that, when we look at other countries, like, when we look at the UK, we believe that, they've been in this field for a long time. So we expect, there'll be more funding, more understanding. And this is what's happening here as well, where we have challenges when it comes to the funding for the essential services with palliative care. So why do you think this issue still persists or exists in countries like UK? I mean, in our country, we understand this is a new field, but in UK, it's been a very well-established field for a long time.
I think that's a very good question. And I think there is a real debate about the value still of palliative care and its services. And people look at what might be core provision, for example, for what the National Health Service might provide. But actually, a lot of that sort of softer, wider, holistic care is much harder to articulate, it's much harder to show and demonstrate benefit of what it does. And where there's a limit on resources, it's often left to one side. And it's really important that we start to show the importance of the care that we provide, and for patients and families also to have voices to speak up about the care that we provide. But it is an ongoing issue, and it's really why our community engagement is really important. We couldn't survive without the community engagement.
Certainly, I mean, I've seen the volume of people supporting your service, and certainly I think this is the main reason for you guys keep going. So for us to learn from you when it comes to advancing palliative care, what lessons should we learn from you so we can expedite the process of implementing more robust palliative care services in our region, especially in UAE?
So there's probably a number of different things, but I think the most important thing is that you start to create a culture where you can begin to talk about death, dying and loss, and to value it as a part of life, and to be able to have those open conversations and to be able to engage the community as well as healthcare professionals in what you're doing. For us, in palliative care, for us at St Christopher's, we have 12,000 roughly volunteers who work and help and support our 500 plus staff who deliver our service. That's community engagement. And I know for others, I know from Dr. Raj, if you look at other countries, that community engagement and that volunteering has really been a bedrock also of the services that you provide. And I wonder how you might start to channel that and address that here in the UAE.
Certainly, I think volunteering is a very important aspect, and the other aspect that you also been working on is advocating with the regulators and politics. I've seen that you're working with at the Parliament as well, trying to spread the word. So I think engaging the regulators early is very important, because without them being engaged and aware, we cannot move forward with any services. Dr. Khamis, thank you so much for all the work you do, and I don't know what to say about what's happening there, but my question for you, are you able to access any opioids during this time? I mean, I know you've been doing all this education and training, but do you have access to opioids to help patients?
Thank you so much. Thank you so much. And thanks for the organizers and for my two speakers. Prior to the war, we were able to have a very, very long battle to change the regulations and to fight in all aspects to get morphines and other opioids to our patients. And we managed, yes, we succeeded to bring opioids, especially oral opioids, to our patients over the last year. And in the Turkish Palestinian Hospital, which one of the photos at the end of my talk really shows that very, very modern hospital. We managed that since the beginning of the war, everything was cut, including food, water, and medicine. And one of these medicines is pain medicines. So we have really to manage some of the patients with basic modalities. In fact, some of the patients who have to undergo some minor procedures, we do it without any anesthesia, which is completely against the first statement that they put in one slide, that pain relief is a basic human right. So every patient should live without pain and should die without pain. But unfortunately, due to the current circumstances, we have to come with some other
I think signals are very weak, but any other questions to Dr. Ross before we conclude? Yes, please.
Hi, Dr. Ross. I'm Kim. I was wondering, I work in Saudi Arabia now for 8 years, but before I was in Canada, which I imagine is a similar reality. And like in Canada, I imagine UK, the major population we're having struggled palliative care, I believe, is the old people, Alzheimer, dementia, that lives over a very long span of time and unfortunately don't have family to take care of them and things like that. And in places like Saudi Arabia, this is a very small number. I don't know about UAE, how it compares. We're mostly dealing with cancer patients. But I'm thinking, you know, with the healthcare system improving in the area, people are living longer. So at some point, we're going to be facing the old age, frailty, dementia. How could like these countries prepare before so they're not caught up like UK and Canada with this particular population that I find very, very challenging, more than the cancer patient?
I think it is challenging, and it's challenging because there's individual conditions that you're dealing with, and then there's also the issue around multimorbidity as people get older and are living with frailty. I've learned an awful lot from my geriatrician colleagues, and I think it's really important that as you start to think and plan for the future, that you work alongside each other to bring your different skill sets to the table. That would be one thing. My experience has also been around working particularly with heart failure, and mainly again in that frailty population. And you saw on one of the slides earlier, the symptom burden for those patients with non-cancer diagnoses is as bad and sometimes worse than it is for our cancer patients. So it is really key that we find ways to start to develop those resources for them. And the principles of palliative care are still the same in applying them, but perhaps the way and the models of care that you might give, whereas for a cancer patient, it's quite a clear trajectory most of the time, although not always now. It really isn't for those with non-malignant diagnoses, and they have these episodes of decompensation that you need to be alongside for. And then you can step back for a while and come back in again at different times of need. So it's about thinking differently as well as a team, and also upskilling your team and educating them around some of the other conditions that they'll be managing.
Thank you so much. We'll go back to Dr. Khamis. I think he's back online. Dr. Khamis, we're talking about access to opioids in Gaza and if you are able to provide it for your patients or not.
Prior to the war, the current war in October 2023, we managed to fight different battles with different regulators and through WHO support. And we managed to bring morphines and other opioids to Gaza Strip. And we even managed to
I think the signals are not the best as we expect from Gaza. Anyway, would like to conclude this session. I would like to thank Dr. Catherine, Dr. Khamis, and Dr. Joy Ross, and I would like to present this as a thank you. Please.
Can you hear me?
So with this, actually, we reach the end of our session 2, and we'll take a break until 1 p.m. So it's a lunch break, and we'll see you back in half an hour. Okay?